Okay, I think we will start, and then if there's more friends who are going to join us, that's great. I wonder, since I don't think there's going to be like 10 times more people, I mean, I wonder if it's going to be like make sense for everybody to be on this side. I mean, you know, or closer, just so that like it's easy for eye contact, and then there's going to be group work, and so thank you. You want me to close? Yeah, thank you so much. Oh, you see, it already looks busier. Thank you so much. Excellent. All right. Well, thank you so much, everybody, for being here. I'm Lisa Scher, one of the course directors and presenters, and really appreciate you choosing this course. I mean, there's the program this afternoon is really rich, so appreciate you being here. And hopefully, there will be a didactic session, and then there will be also very small group participation and case discussion. So hopefully, they'll be very helpful for everybody. Okay. Oh, this is interesting. It's not. I see it advancing there, but not here. Okay, so our DEI statement. I'm just trying to make sure I can actually advance the slides. Now I can advance them here, but not actually on the, let's see, maybe it's. I don't know if anybody can help with the tech support. Yeah, for some reason the slides, I cannot see them advance here, but not on the, not projecting. Or resume slideshow, okay. Well, not sure. Yeah, please.
Is it back on?
Someday, I guess
Where's your presentation?
it's on this, it's on the slide. Let's see.
Gotta put it on the desktop. That's fine. Gotta move it over to the desktop.
How do I? What I did? Where, can you help me open it? Find it? Oh, actually, here it is.
Yeah.
Thank you so much. Okay, excellent. All right. Well, the first challenge has been conquered. Okay, so this is going to be our schedule for today. So I will be talking about some changes in listing and management, some updates in the lung transplant, psychiatry. Dr. Mutalik will talk about updates in living donation. Dr. Phipps will talk about updates in toxicology testing. Dr. Hussein, updates in early liver transplantation. We'll have a break, hopefully find coffee, you know, bathroom breaks. Dr. Winder will talk about updates in VCA, and then we will have the interactive part. So kind of a lot of stuff to go through. All right. I don't have any disclosures. So there's a bit of potpourri of everything, but my specialization, right? So I'm associate professor at clinical associate professor at Stanford, and I consult, you know, to transplant programs, and in particular our lung program, heart and lung program. And so my focus will be kind of that. Those are the lens that I'm seeing. So, but there's a bit of potpourri in some changes, some improvements that we see, and also management of acute lung transplant patients. So a little bit of the statistics of our lung transplant patients. So approximately, you know, 4,600 patients actually get lung transplant every year, which is pretty incredible. 80% of them bilateral. Of course, 20% is single. And the median survival is actually the shortest out of all solid organs, right? So I would say on roughly on all other organs, roughly median survival in heart, liver, kidney, 10 to 12 years, right? But for lungs, for years, I've said 5 years, and I just had to now readjust. Maybe the last few years, it's actually been 6 years. Yay, great. And for pizza, it's actually a little bit less. And that's because, of course, you know, of the really active immune system, which actually, you know, and these are the challenges while our lung transplant recipients do die sooner, right? Lungs are in the contact with the environment. It has a very active immune system. And actually, if patients do survive the first year, mortality is roughly 10 to 20, up to 20% in some programs, right, in the first year. But if they survive the first year, then of course the expected survival is greater. So if they make it the first year out of the hospital, right, that's great. Bit of a busy slide, but just, who gets transplanted, right? So it has changed maybe a little bit, right? COPD makes approximately a quarter of patients who get lung transplant. CF, right? This is not my other specialty, at Stanford. It has been roughly 15%. It actually has been changing. We'll talk a little bit about the new amazing CFTR modulator therapies that have come out in CF. So now when they look at the percentage of people who get transplanted for CF now after those modulators, it's actually 25% of the volume that was transplanted before. But these people might be actually more complicated. CF patients in general, they actually do better. Their survival is one of the best, but we don't know now the patients who do get transplanted now if their survival is actually going to be as good because they're more psychosocially complicated. And they also have different mutations, and does that somehow contribute? For example, right now, the young man that they're going to list at Stanford, Dr. Hussein, I'm so glad you didn't see him, or Dr. Maldonado, because, So these are most complicated, right? Psychosocially complicated patients. IPF, right? Pulmonary fibrosis, approximately a quarter of patients. Pulmonary hypertension, we see a lot of it at Stanford, but it's roughly 3%, right? And then there's retransplant and other, but this is roughly kind of the breakdown that we see. What are the challenges in lung transplant patients? Well, morbidity and mortality, again, come from the immune system, right? Not surprisingly. So people die early on for primary graft dysfunction, right? Early on within the first year. And then later on, a lot of people do develop chronic lung allograft dysfunction, which is really a chronic rejection. And that's really what limits the survival. And this is what comes up for us. Right? If we see them in the hospital, that's because they dyspneic, which we'll talk about. And if we see them later, that's because they're struggling with not being able to breathe again, right? So, understanding that is very relevant to us. There's, of course, donor shortage. We'll talk a little bit as it relates to other organs that could be donated, even though, of course, lung also can be, part of the lung can also be donated. And so, so kind of really what the field is trying to work on is, expanding, donor pool, right? Selecting, patients appropriately, and then really working on, primary graft dysfunction and the chronic rejection. There's been a change in the listing system, and we'll get to that, right? But the problem has been that especially particular patients, particular people have been suffering and dying more while waiting for the lungs. And for example, women, because of the short stature, right? So, the size has to match. So it's harder to match for smaller women. Also, there is more pre-transplant allosensitization, right? Especially obviously if women, had children, right? So more antibodies, it's harder to find organs. Patients with CF, again, because they're smaller. Patients with pulmonary hypertension, because, sort of how they were listed, it didn't really catch how truly sick they were. So they were not high enough on the system, right? On the list until they really crashed. So some patients have been disadvantaged. And the lung allocation system came into effect in 2004, and it was just replaced by a continuous allocation system a little bit more than a year ago. But even with lung allocation system, they actually have been already improving the survival. But this what's been interesting is that, so it was determined by two major factors: risk of 1 year waitlist mortality and likelihood of 1 year post-transplant survival. But as you see, risk of 1 year waitlist mortality, it was double counted, right? So, kind of they cared more about people not dying on the transplant list as compared to surviving, right? Post-transplant. And we see those patients, very sick patients, they make it, and then they dwindle and they don't do so well. And then there's other factors that we discussed, they're not automatically accounted for. And there was strict geographical distributions within 250 nautical mile radius. There's a reason why nautical mile radius, but I don't know. Right, so it's kind of within certain regions. So now, as of March last year, we have composite allocation scale, right? And really all organs are moving to that. It's continuous. So first of all, now the probability of dying on the wait list and the 1 year survival, they're rated 1-to-1, right? So we want people to survive that first year just as much as we want them not to die. And there are some other things that I've taken more into account, like if somebody what is their blood type, right? Or if they have a particular disease, or their HLA antibody sensitization, right? And so everybody gets a score, but now the organs can come from the whole country, right? So there's no more geographical regions within the country. And because of the improvement of how organs are transported, it is possible, right? So everybody has the score, but then they matched with that particular donor. So let's say I'm in California, right? And there's a donor with a particular score, right? Particular medical urgency. And then there's a recipient, right? And then the donor is, right? So, and then there's donors also in California. So obviously the score is going to be higher as if the recipient was in New York, right? So obviously if they're exactly the same recipients and the donor is closer to them, right, they will be weighted highly, higher. But it's still possible to potentially, travel for the organ now across the country. And at Stanford, where we do see really high, sick people, we definitely have seen an uptick in lung transplantation, right? The, patients, recipients, donors, well, everybody comes from all over. And, right, the expectation has been that, that it would improve sort of survival, right? There will be more transplants, and that's what we're seeing so far. When they analyze that, obviously still early. It's only been a little bit more than a year, but it does seem that the transplant rate has increased by 16%. The waitlist mortality decreased by 30% because patients, right? Those patients who are, like, let's say they're very sensitized, they get many more offers, right? So they get transplanted sooner. And overall, the distance, of course, right, between the donor and recipient has increased as predicted, right? So the hope is that it actually will benefit everybody. Okay, so that's the listing. And of course, right, there's just ongoing to be shortage of donors, right? So really, the lung transplant and other communities, right, really thinking and brainstorming, right, what can be done, right, to improve that. So there has been an increased use of donation after cardiac death, right? So kind of, the gold standard in the field has been, kind of brain death, but there's more and more donation after cardiac death in both lung and heart transplant, actually, right, which is incredible. And Europe and Australia have been more leading in terms of DCD donors. So up to 40% of their donors for lung transplant are actually DCD donors, which is incredible. And now in the US, right, they're really trying to work on that. And there's even collaborative, organized through the International Society for Heart and Lung Transplantation, and the programs, and I think Stanford is one of them, who are part of that, are doing more DCD transplants, right, as compared to those who are not. So the really is it, right, there's might be more ischemia time, right? There are, of course, concerns, right? So the outcomes, it does take time to truly compare those outcomes. But again, right, there definitely have been a lot of other developments that have allowed even for the change in the allocation system, right? So now, organs, they can travel a longer time, right? And now we're taking in riskier organs as well. So for example, with ex vivo lung perfusion system, which allows for the lungs outside of the body to be perfused and ventilated, right? So if lungs are of uncertain quality, if we need to reperfuse them and see what happens, if we need to treat them somehow, right, even with medications, this really provides additional organs. And it seems that when they're chosen well, the outcomes actually can be comparable to those lungs that's not, they did not require the EVLP. And it does seem that it increased the usable lungs by up to 30%, which is pretty incredible. So that's definitely something to to keep an eye on. And they will also indicate it in the chart, right? So EVLP was used for those lungs. So just multiple uses for those, which I think is really interesting. For example, they can do immunomodulatory treatment to reduce primary graft dysfunction, right? So do some treatments while those lungs are being perfused and ventilated outside of the body. And for example, if they have HCV or some other, infection, they potentially can be treated with antimicrobials. So there's a lot more that can be done. And at the same time, right, I guess even potentially before they get to EVLP or maybe after, there's better transportation of lungs as well. Right, before pretty much like cut out the lungs, put them on ice, lunchbox, and travel, right? But the uneven, right, cooling and freezing of the lungs will damage the tissue. So now there's fancier coolers, right, where with a fancy distribution of cooling system so that they evenly, cooled, and they can be stored there for a much longer time. And this is what actually allows for the organs to travel, across the country if need to. So it's kind of exciting to see there's a lot of these technological advances that we might not be aware of, but that really allow, right, for increased, transplantation and for us to be seeing more patients, right? So it's interesting to see that behind the scenes. And so far, it seems that potentially, right, this better transportation of lungs, right, these machines and this better system, right, actually might potentially decrease the primary graft dysfunction, right? Because the lungs are not damaged in the process of transplantation as much. They might need less ECMO, right? Kind of other circulatory support after transplant, and even potentially less renal dysfunction. Because I'm sure, especially those of us who see patients acutely in the hospital, right? There's a lot of renal dysfunction acutely in our lung transplant patients, multiple factors. But usually you can see that if lungs are not doing as well, kidneys are also not doing as well, right? So by preserving lungs better, we are also supporting kidneys. Another way to kind of extend the donor pool, right? And that would apply to really all organs, including lungs, is really using more extending donor criteria, right? So we're using older donors. We're taking patients who have, smoking history, known drug use, right? Other comorbidities. And right in the US, they also have an increase potentially in donors, unfortunately, because of the opiate epidemic, right? Because where do lung donors, come from, right? These are all sad stories, right? They're all sad stories, right? Overdoses, suicides, car accidents, right? So substance use is involved on that other side. But right, with the donor pool, there's also potentially might be higher risk of having some illnesses, right? Some other infections such as HCV infection. But again, now we potentially can even treat those patients, right, while they're being perfused and ventilated, the lungs are perfused and ventilated outside the body. So all these advancements working together can definitely increase the donor pool. We are also using more ECMO, right? Extracorporeal membrane oxygenation. I mean, I do wonder how many of you work like in acute settings in ICU? Okay, great. So you see this all the time, right? Great, right? So and of course the use of ECMO really has increased during COVID time. I mean, I remember walking through our ICU and it's like literally just managing ECMOs, at which point Stanford started using phenobarbital. So, but overall, right, from, the use of peri-transplant ECMO has increased from 5% to 9%. It almost seems even more, right? But there's some of the patients are carried over, right? Now bridge with ECMO. And there's also increased use of ECMO post-transplant, right? If somebody does have now primary graft dysfunction, it's severe, and the lungs are just too stiff, right? Using the machine to help with the oxygenation and removal of carbon dioxide can be, is very helpful. And we are consulted, we're seeing those patients all the time, right? To manage dyspnea, anxiety, delirium, and overall distress, right? And few things, few important factors. One of them I'm not really going to go into is, to know, but ECMO, there's a huge component of sequestration. You need higher drugs, much higher amount of drugs for the same effect, because often, especially lipophilic medications are being sequestered by the ECMO machine, right? They both go into the, so for the PVC tubing, but also they get sucked up by the membrane oxygenator as well. And also there's increased volume of distribution as well, right? So three things. So there are definitely tables you can look up. Dr. Maldonado will publish his amazing paper on ECMO when that comes out. Read it, right? But you will need higher amounts of medications, right, for patients on ECMO. And these patients are uncomfortable, right? And they're dyspneic, right? They struggle, right? They struggle breathing. So how many of you have seen acute lung transplant patients and you were consulted for anxiety? Okay. How often that was because the lungs were not working as well? Okay, right? Exactly. So hence my new obsession. Dr. Hussein's like, oh my gosh, 10th time I'm going to listen to the dyspnea talk. Yes. So, we are consulted for those patients, right? And this is because their lungs don't work and they are much more likely to be anxious, right? And we still can help, right? But I think kind of for us to really understand what's behind of it can be very helpful. So what is dyspnea? It's a subjective experience, right? So patient tells us that they struggle breathing, right? And I think that's the part that our medical, kind of ICU pulmonologists, they struggle with. They're like, but they look fine. Like they just got new lungs. If they tell me they can't breathe, I kind of trust them over you, even if their respiratory rate is okay, right, for now. Right, so it's reported. And it's one of the most distressing symptoms that people can experience in ICU. It's really, the most distressing is actually lack of sleep. Apparently people are really tortured by lack of sleep in ICU. But the second most distressing is the dyspnea, because it truly feels like I cannot breathe, I'm suffocating, I'm dying, right? And then if everybody's invalidating you, you're like, and nobody's helping me. I'm dying and nobody's helping me, right? And what I appreciate, there's a particular kind of, there's ICU doctors, especially in France, who are like really working on the movie. And they coined this term, which I love, respiratory related brain suffering, right? Which is, it's like there's a lot of words, but then when you say it a few times, like, oh my gosh, it totally makes sense, right? It's the brain. Of course, it's the brain, right? That does that. And if our patients are not able to communicate because they're delirious or because there's no way to, it's even harder to pick it up, right? Because as I just said, it's a self-reported experience. Dyspnea is not studied as much, and it's also not, we don't monitor for it yet. I think it will change, right? Because we monitor for delirium, we screen for delirium, we screen for pain. Why not screen for this like really distressing symptom when people think that they're dying? But there's few studies have been done. This particular study was actually in lung transplant recipients, right? And it was through retrospective chart review, right? So it's not that the patients told somebody and now reading from the chart. So it might even underappreciate it, right? But 63%, this one was documented in 63%. I'm impressed that they documented it, right? But that's pretty good. Risk factor was bilateral transplant as compared to single, makes sense. And anxiety was 18 times more likely. In general ICU patients, as I will get there, it's like roughly 9 times more likely, still very high. In this patient, it's pretty much if you dyspneic, you're gonna feel anxious, right? So it's pretty much like 1-to-1. That's what it tells me. And these are lung transplant recipients with documented dyspnea. They do need delayed rehabilitation, delayed weaning from mechanical ventilation and long ICU stay, right? So again, how many of you have been consulted, right? Because it's difficult to wean patient off the ventilator, right? Or you cannot tolerate trach, right? Like it's all because of anxiety. It's all in their head, right? They just do not want to leave the hospital. Sure. All right. So and it's brain related, right? The pathophysiology of dyspnea arises when there's a mismatch between very simply what brain tells the lungs to do, and the signals that the brain gets back from the lungs, right? And there's a mismatch. The brain is gonna feel that like, oh my gosh, you're not able to do what I needed to do. And there are 3 main mechanisms that then give the sensation, then if there's something goes wrong, then they give to the sensation of dyspnea, right? Increased work of breathing, air hunger, and chest tightness. These are different flavors of dyspnea. So, really quickly, right? So first of all, right, our motor cortex gives the signal to the intercostal muscles, which we also need for breathing, right? And the brainstem, of course, via the phrenic nerve to diaphragm, right? So it gives the impulses, but at the same time, there's actually what's called corollary discharge, right? There's a copy made from the motor cortex to the sensory cortex, and it's like remembers, this is what I told lungs to do. And then whatever it gets back, it compares. Is it doing what I told it to do? And if not, there's going to be a sensation of dyspnea. But from this mechanism particularly, this is when the people feel like, I have to work harder to breathe, right? At the same time, right, there are peripheral and central receptors to pH, to CO2, and to and to oxygen, right? And again, if they're off, right, like for example, if the patient is hypercapnic, they're gonna feel that. They're gonna feel I'm not getting enough air, right? So you see a patient on the AVBG and you see that they are acidemic and their CO2 is high, and they're gonna tell you, I need more air, right? And then there's chest tightness, right? At the same time, right, there's a stretch receptors, right, through the lungs, right, through all the muscles, right, and they pick up, right, if there is mucus, if there is, other stuff that shouldn't be there, right, infection, whatever else, space, and there's going to be the sensation of chest tightness. So it's obviously it's very complex and quite uncomfortable. But this one, I mean, I've tried to look it up in literature, but I'm also just like really curious because obviously there's some like denervation, and I wonder how some of that is also affected, especially in the perception of the chest tightness, those kind of peripheral stretch receptors. And contributors of dyspnea, right? Let's say, okay, it just takes time, right, for the brain and the lungs to start all working nicely together. But even, for example, the ventilatory settings, right, some of them can contribute to the issue of dyspnea. For example, if patients are not doing as well, maybe they do have a bit of a primary graft dysfunction, right? They need to put them on lung protective ventilation, which means low volumes and permissive hypercapnia. It's going to increase the sensation of dyspnea, right? And multiple other factors are also going to worsen it. But that's sometimes it's important for us to appreciate. And as I already said, right, these patients are more likely to be anxious. It's harder to wean them off. And long term, this is the significant risk factor for PTSD, right? So we're going to see these patients for post-traumatic stress disorder. They're going to tell you how they were tortured in ICU. And these are the patients who are going to tell you they don't want to, let's say if it comes up, to be retransplanted because this was complete torture. And honestly, when you look at those patients, you're like, this is tortures. I don't know. I'm not sure, like, how many, I want to ask how many of you would want to get transplant, but I'm not going to ask. Anyway, I'm not going to ask. So, right, but dyspnea is a risk factor for PTSD, right? Not surprisingly. And so we don't screen for that routinely. I do ask now, actually, I do ask. If somebody tells me that somebody's anxious, I will ask them, do you have difficulty breathing? And then follow up with, okay, well, tell me on a scale from 0 to 10, right? 0 is like your breathing is super comfortable, you're doing great. And 10 is like the worst. You feel you're suffocating, you know, and then we'll give you the number. And then I would ask them, do you feel like you're not getting enough air, right? Or do you feel like you have to work hard to breathe? Or do you feel like your chest tightness? Trying to appreciate that, right? And even sometimes by asking, patients can feel very validated, right? And there are situations where truly the medical team is doing everything that they can, and they will tell the lungs are great, but the patient's still ventilated. There's some pain. There's some anemia, right? Like they've been there for a week. They have deconditioned. They've lost some of their muscle mass. It is hard for them to work, right? To breathe. There's just a little bit of atelectasis. Who cares, right? But all that adds up, right? So just even for us, like, you know, acknowledging and how we communicate with patients can be helpful, right? And I will tell the patients, yes, I know you're uncomfortable. And I wouldn't, in a very like simplistic, I will tell them about the complex, you know, brain-lung connections. It's going to take time. I know you're uncomfortable. You are safe. We know you're suffering. We're going to do the best we can, but also just kind of, you know, you also have to keep working. Part of it, if everything truly is stable, nothing can be done, right? Like we don't need to adjust ventilators, right? We're not going to transfuse them, right? Then it's about coaching as well. How we coach them can be important. There's also dyspnea tools in non-communicative patients, and you can definitely look it up. The slides are available. This paper is fantastic from Dimuli, from France, and there is a link to this calculator. So just like incredible paper on dyspnea. And then let's say somebody, you know, a patient is, you know, a week out after transplant, we consulted for anxiety, dyspnea, right? And they tell us lungs are great, right? As I told you, you know, there's a bit of this, a bit of that, but there's nothing that's going to acutely change, right? Like they don't need further antibiotic treatment for infection, right? They feel like they optimize the vent settings, right? But sort of what can we do, right? What can we do? So, you know, it is considering, right? We can't really things, so let's see. Right. So, I mean, we do want to see for patients, first of all, sometimes we have to understand, are the ventilatory settings optimized? And sometimes it is up to us to ask, right? We're not an experts, but working with the team, right? Is something needs to be treated, right? We could consider non-pharmacological interventions, like for example, cool fan actually is helpful, right? Or, you know, or mindfulness exercises, or relaxation, or distraction, or psychoeducation, right? Again, as I said, you know, if we can manage pain and everything else, right? But if not, if everything is managed, right, we can work with the teams, right, with understanding, and also help them with medications to manage dyspnea-associated anxiety. Again, I know it's small. Okay, are you able to see it? Okay, right, but the slides are available. You're able to, you know, and this is in our paper as well. I'm sure this is what all of us are doing already. This is like nothing brand new, but this is just kind of how we think about it if we're consulted, right? After we look, can ventilator settings be optimized? And then, you know, they laugh at us like, oh, what do you know, right? Right? But you know, like, again, sometimes it is explaining to the team, like, listen, it's reminding them, right, that they've been deconditioned, they are a bit anemic, they do have pain, right? There's this and that. Like, it makes sense. What they feel is real. I know there's nothing else that you can do, but it's real, and it's important how you talk to your patients, right? That can be helpful. Not that like you're fine, because again, that makes people to be very invalidated. But again, saying that I know you're uncomfortable, but you know, we're doing everything to keep you safe and comfortable. And then medications wise, right? So what medications actually have evidence for dyspnea? If anybody's brave. Opiates, I know some other part of this lecture is gonna like totally say how opiates are bad. But for this part, right? And obviously delirium, you know. But for dyspnea, sometimes we have to use opiates. But what we can also do, we can help with the dyspnea-associated anxiety, right? And we've even used benzos if patients are delirious, right? And we need to give them something extra before the vent change or the trach wean. We have used benzos as well, right? Again, short term, we can consider other things such as hydroxyzine or Seroquel, really thinking about antihistaminic medications, right? If it's a bit like moderate, you know, it's going to be a week or so, right? We might start them on guanfacine, alpha-2 agonist, right? Pregabalin, and then use the PRN options. And if it's longer term, right, if we know, okay, we're here, you know, It's going to be some time, right? We might start even SSRIs, right, and or mirtazapine, right? Because it's also going to actually help with some synaptic remodeling as well and modulation of dyspnea cessation, just the way it is done in pain. So there are some options, right? But again, we're treating dyspnea-associated anxiety. Okay, all right. So just again, right? There's also increasing the recipient pool, right? All the patients are being transplanted. And when they are very carefully selected, it seems like the outcomes for lung transplant might be just as good as for younger patients. In this study, they compared patients below 70 to older than 70, and they chose them very carefully. And still early it was published in 2022, right? I mean, I think we're still learning about that. But, for our sake, right, we will be seeing potentially patients with more cognitive impairment, right? And potentially more delirium as well. And this is also, but some patients we're not going to see as much, right? I told you about the CF, right? And the incredible breakthrough has been the creation of CFTR modulators, right? It's genetic disease, right? We all have CFTR, gene and protein, which helps with sodium chloride and water, but it's mutated in patients with CF, right? So they cannot, right? So that conductance of the electrolytes and water is not great. So the mucus is very thick, right? And it traps bad stuff in lungs and, other organs are affected. So CFTR modulators are literally these incredible molecules, and Trikafta is the latest one, where they come in and they stabilize the protein, right? They help to get it to the cell membrane and help to open it properly. So now sodium chloride flows, water flows, like mucus is thin, and it's truly amazing. The lung function has gone up. People have come up the transplant list. We think that the survival is predicted to be into 60s for people who are alive today, right? So it's for people who are born today. So it's actually pretty incredible, right? So we're not going to see as many people with CF for transplant. Maybe we just defer that. We don't know. Maybe we're going to see them later when they're old and they have other comorbidities, right? We don't know yet. But I think other patients might have more psychosocial contraindications. All right, so overall, right, so we kind of talked about just some of the changes in the field, right, expanding the donor pool and some of the advances that have come, but also thinking about how recipient pool is changing as well. And we talked about, of course, a bit of, in terms of the lung transplant, right, and ECMO use and the dyspnea and what we can do as transplant psychiatrists in the acute ICU setting. So we will continue, like they need us, right, no matter of all those changes, they will still need us, right? And we'll keep being there. Thank you so much. And now I'm gonna give the stage to Dr. Mutalik.
Hi, everybody. All right, it's working. Okay. Thank you so much for being here and for spending this afternoon with us. I'm going to be talking about living donors. And I want to say that on a day like this, I think it's particularly poignant to hold in our minds and our hearts the fact that while there is divisiveness and hatefulness in human nature, there's also goodness and benevolence and compassion and kindness and generosity. And what drew me to working with and understanding living donors was really sort of this benevolence that I was blown away by. But the psychiatrist within me also wanted to dig a little bit deeper and understand it. In terms of what I hope to cover in the next 35 minutes, I want to discuss the psychosocial evaluation of living donors and go over some pertinent clinical and ethical dilemmas and do a deep dive into the why or the psychology of altruism, touch upon a little bit of the updates in transplant medicine as they pertain to living donors. So why do we talk about living donors, or why is the necessity for living donors? So as we know, we live in a world in which organs are a precious and scarce resource. If you look at the organdonor.gov website, it's full of these statistics. 17 people die each day waiting for an organ transplant. Every 8 minutes, another person is added to the transplant waiting list. And even though there are some ways of harvesting organs like xenotransplantation, there are some advances like organox or normothermic perfusion pumps, etc., that have expanded some of the options for donor livers to be used. We still are dependent on the largesse of living donors. in terms of the bioethical principles, the foundational principles of bioethics, they all intersect in living donation. So we want to, of course, uphold and support autonomy, self-determination, a person's ability to make their own decisions and choose to be an organ donor. But at the same time, we also want to do no harm. There is beneficence to the recipients. And as we'll talk about a little bit, possibly some beneficence to the living donors as well, in terms of a sense of meaning and feeling good about the donation. And we'll talk about that a little more. And of course, the principle of justice is really quite prevalent all over the transplant world because of the concept of equitable, fair allocation of this precious resource. So the organ procurement and transplant network also includes the ethical principle of utility, which broadly means the greatest good for the greatest number. In terms of, we've talked about what's ethical, the ethical principles. In terms of the legal framework, as we know, in 1984, the National Organ Transplantation Act basically has made the buying and selling of organs illegal, which means that this cannot be a transactional, compensated kind of interaction. But at the same time, that doesn't mean that donors cannot be reimbursed for lost wages or dependent care, travel expenses, etc. There's another principle in the transplant world. I don't know if anyone's heard of double equipoise. Does that term sound familiar? So it's interesting because clinical equipoise is one way of saying that in any intervention clinically, the risks have to be balanced by the benefits. So that's clinical equipoise. And double equipoise is actually considering the donor and the recipient as part of a dyad. And the risks to the donor must be balanced by the benefit to the recipient. And of course, I mean, this goes without saying, but at the same time, this can get a little complicated depending on the relationship between the donor and the recipient. It can also get complicated depending on the prognosis of whatever condition the recipient has. So just a reminder of the basics of organ donation. So there are directed donors and non-directed donors. So non-directed donors, of course, are donating to the pool of recipients, and directed donors are donating to a specific individual. And this person can be somebody who is either biological or close emotional relative. And it can also be a directed donation to somebody specific, but not someone that's more than an acquaintance. So for instance, someone that, you know, you see a flyer or you see on social media. So that can happen as well. And of course, the first step in organ donation is blood group compatibility. And then there's histocompatibility or tissue compatibility that's checked. And this also sort of can create some interesting ethical questions if you think about utility. So if you have somebody that is a universal donor, right, blood group O, even if, you know, they can clearly, because they're a universal donor, let's say they're able to, you know, very easily donate to a specific recipient or an intended recipient, there is the question of, in a world of an organ shortage, should there be a discussion with them about the possibility of entering the swap so that they can help more than one person? All right, so to go from the abstract to a little more grounded in a case, this is actually a hypothetical case that's kind of a composite of many cases that I've seen. This is a gentleman who comes in with the chief concern of, I have 2 kidneys, some people have none. This is a 30-year-old male who wants to donate a kidney to a stranger. And let's say that he heard about it on a podcast and said, oh, well, you know, I had a light bulb moment. I have 2 kidneys. You only need 1 to survive. And some people have none. No, it's morally incumbent on me to do this. I must do this. He feels inspired. He also has a history of what we call pro-social behavior. So blood donation has been on the bone marrow registry. So before I go into what we would want to know about, a show of hands, how many of you can imagine donating, let's say a kidney, just to make it specific, to anyone in the world? Okay, so we have a few people. Now, how many of you can imagine donating a kidney to a stranger? Okay, so we've had a little bit of attrition. So I'm wondering, and no pressure because I know this goes into some like personal territory, but would anyone who sort of raised their hands for the first round of questions and didn't for the second be able to speak to why not, or why you would raise your hand to donate to somebody specific in your life, but not to a stranger? Oh, sorry, no, sometimes well, the question was basically, who would feel comfortable or who would ever contemplate or be able to imagine donating a kidney to someone in their life, and or anyone in the world? And some people raised their hands. And then my next question was, how many of you can contemplate donating a kidney to a stranger? And then like a few hands went down. So I was just curious if anybody can speak to like their thought process. Yes. Hmm.
Awesome. Notice it. If somebody shows up at your house and says, I'm here to give you tens of thousands of dollars,
Hmm.
that action pattern might do that. However, somebody that you know or somebody that you trust, you know, gift them, it seems more intuitive. And some of the most difficult cases that we have had in my practice were people who were non-directed altruistic donors. And why was because on the face of it, they were brave and they were heroes, and not to diminish what they did, but there were some deep-seated reasons why they were something of kind of like a redemptive value. But again, I am not diminishing their sacrifice. But what happened afterwards was so difficult for them that this calculation of should they have ever donated really came into play. So I think that has given me pause.
Right.
Would I ever, I have a brother-in-law who donated to my father-in-law and saved his life. There were a lot of complications. I think when you accumulate these experiences, you look at it one way, maybe that's why all of us are a little bit hesitant.
Right.
But if you're coming off the street, you see it on social media, you don't have a context for it, you might be a little bit more brash and cavalier about, hey, I've got two, some people don't have one.
Right.
What's wrong?
Right. No, thank you for sharing that. I'm sure, I'm hoping to be able to continue this discussion in the small groups. And I guess what I will say is certainly, turning the question onto myself, I've sort of along the same lines reflected on how there's a little bit of a selection bias, because I see as a physician, not just with organ donation, but just random surgeries going horribly wrong, or people having like intractable fatigue or pain, or I've seen things go wrong. And so I think that while I can imagine myself to my spouse or a parent or a child certainly donating, I think that to me there is sort of the sense of, why would I go out of my way to sort of do something that could possibly mess with my health? So I think that this is a very, very common sort of reaction that people can imagine it with the closer the emotional relationship. So what is the purpose of our psychosocial evaluation? So we want to identify pre-donation psychosocial vulnerabilities that may lend themselves to a poorer psychosocial outcome. So here I'll reference the stress vulnerability model. So if you look at the surgery as a stressor, and the pain and the recovery and the challenges after that, we are trying to identify vulnerabilities that might get activated or triggered or pose challenges post donation. And of course, within that there are absolute contraindications or red flags, and then there are yellow flags or relative contraindications. It can be that you can donate at some point, but just not now. Maybe get certain things in order. We want to identify and get a sense of what their motivation for donation is. Of course, we want to get a sense of psychiatric stability, substance use disorders. And within that, we do an informed consent or capacity evaluation, right? You want to get a sense of if the person understands and appreciates the risks of the procedure. Ambivalence, as we'll talk about in a little later, lingering ambivalence is associated with poorer psychosocial outcomes. And so that's one thing that, of course, we want to screen for. This has to be a voluntary decision that's free of coercion. We want to get a sense of the relationship to the recipient. Also, biopsychosocial formulation, right? You want to understand, is this a value, a long-held value? Is there a history of pro-social behavior? What is the decision-making style of this person? Is it an impulsive decision? Is it consistent with prior decisions? We also want to make sure that the person's not left worse off, right? So in terms of their personal situation, financial situation, professionally, there are validated tools like the living donor assessment tool that we use at our center. There's the PsyPat LD that I know Dr. Maldonado has developed. There's the LPAT, and these can be used to supplement a narrative evaluation. Of course, as we talked about, understanding of the donation process. So another question, how much do you think a living donor needs to understand of the recipient's condition? Yeah, and can you say more or any examples that come to mind? Yeah. Right. Right. No, and I'm so glad you brought that up, because actually a poor outcome to the recipient is a risk factor for poor psychosocial outcome for the donor. And furthermore, I guess two other examples come to mind. Liver donation. So liver donations are actually done for cancers like, hilar, cholangiocarcinomas, biliary cancers, or metastatic cancers with mets to the liver. So I think that you could argue that if a donor does not know the prognosis of the recipient and is expecting that they're donating with the expectation of 20 years or 30 years of survival, that's not full informed consent. Oh. Wow. Right. And quickly, I know there's a lot to talk about, but no, thank you so much. So there's a lot to talk about, but the risks of donation. So of course, most catastrophic risk is the risk of death. With kidney donation, it's 0.03%. With liver donation, it's 0.4%. Any major surgery, obviously the risks of general anesthesia, pain, bleeding, infection. With kidney donation specifically, there is a relative risk that's 3.64-fold 1 year post-donation of hypertension, or increased risk. And with end-stage kidney disease, actually, as you can see, it's quite significantly higher, right? Almost 10 times, like 30.8 per 10,000 versus 3.9 per 10,000. However, it's interesting because there is the concept of absolute risk, relative risk, and attributable risk. So if you see, the relative risks are much higher, but the absolute numbers are still very low. And the question of attributable risk is even more complicated. Like, would they have developed hypertension anyway? Would they have developed kidney disease anyway? That's a complicated question. There is the risk of gestational hypertension or preeclampsia, which is 2.5 times higher. And so I guess a question, and I also found this paper from 2020 about fatigue in living donors. 193 donors were compared to 20 healthy controls, and the living kidney donors actually had significantly higher fatigue and lower vitality 1 month post-donation, and about 12% of them actually reported pervasive fatigue 24 months after. So you can even make a case, as this paper made, for including fatigue or persistent fatigue as a potential complication in your informed consent process. So a big question is, how can we frame these risks in a fair manner so that we're not overstating them but not understating them either? And that is a complicated question, because it depends on health literacy. You can tell someone that, oh, you could have high blood pressure during pregnancy, and they may say, oh, okay, fine, that's all right. But we all know that preeclampsia is not a trivial thing. And how much do we need to explain? So what do we generally consider absolute contraindications or relative contraindications, depending on the case, for donation? So certainly suicidal ideation, psychosis, delusions, mania. And this is for multiple reasons. First of all, these are absolute contraindications because the person's unstable psychiatrically. There are, higher priorities, emergencies. At the same time, it can interfere with decision making. Sometimes, somebody could theoretically be psychotic and be having command auditory hallucinations telling them to donate a kidney, or it can be part of a delusional system. Mania, of course, interferes with decision making. With suicidality, you can imagine sort of a fantasy, right? That I'm leaving an organ behind. Of course, this has to be voluntary. So if there's any evidence of coercion, that's not appropriate. Severe ambivalence, of course, if we suspect that there's a transactional like payment involved, substance use disorders, of course. And we'll talk about this a little bit more. I will say that even though I've mentioned these broad contraindications, there is a significant amount of center variance. So actually, Dr. Winder, who's in the audience and who's in our presentation, and Dr. Zimbrian, they had this great study, which was a survey of 195 kidney donor transplant centers and liver transplant centers as well. Liver donor programs. And this was from the period October 2021 to April 2022. And they got responses from about 53% of programs. And what they found was that active suicidality, psychosis, self-harm, the overwhelming majority of programs, they deemed this as an absolute contraindication for living donation. However, active depressive disorder was an absolute contraindication only in 50% of the programs, and active anxiety disorders in 27% of the programs. And only about 71% of the centers actually supported donors post-donation with local resources, etc. For most centers, alcohol, tobacco, cannabis use was acceptable unless it was a disorder. And interestingly, about 40% of the respondents, for them, cannabis use disorder was an absolute contraindication, but this was much lower than for other use disorders, like alcohol use disorder, cocaine use disorder, opioid use disorder, etc. And as we go into the motivation, so I'll just briefly say about this slide, because we're going to do a deep dive into altruism, that there have been systematic reviews that have looked at the motivations of non-directed donation. And donors have tended to, in these reviews, in these studies, demonstrate a deep sense of social responsibility, but they've also underestimated health risks in favor of the benefits to recipients. What are clinical dilemmas that can arise in living donor evaluations? So one is, I've tried to break it down into different domains. So one is in the realm of informed consent / capacity. So you can imagine a situation where you have somebody with an intellectual disability, for instance, right? And they want to donate to, they really, really want to donate to their brother that they love. So that can be one of the questions there, or that can be one of the concerns there. In the Journal of the ACLP, there was actually a very interesting case report of a patient who ultimately, a donor who ultimately didn't end up donating. But that person had dissociative identity disorder. And there was this whole question of, okay, so should there be consensus between all the alters? How does the person typically make decisions? Do all the alters have to agree, et cetera, et cetera? Then we talked about how much you have to know about the etiology of the illness of the recipient and the prognosis. Then I think that there is this whole question of, on the one hand, you have donors that are acceptable, have no psychopathology, no substance use, great relationship with the recipient, great support system, no ambivalence, strong motivation. And then on the other hand, you have the people that have the absolute contraindications, right? It's like crystal clear. This person's suicidal, this person's psychotic. We can't clear them. I think the dilemmas can all be sort of in the middle. Okay, this person, should I mandate therapy? Should I say they should do 6 months of therapy and come back? Should I recommend that they be on a medication? Do I close them? What is the level of psychopathology that is acceptable to us? And as you can see, that's not universal. There's a lot of center variance. All right. Well, the deep dive into altruism. So altruism is basically other-oriented behavior. It is placing the welfare of others above cost to yourself. And etymologically, it comes from the French autrui, which means of or for others. I will point out that in moral philosophy, the word altruism is not just used to describe the behavior, but it's used to describe this idea that the morality of an action is based solely on its impact on others, regardless of the consequences to the agent or the actor. There is a book called Strangers Drowning by the journalist Larissa McFarquhar. And when we talk about reactions, countertransference, bias about donation, this is a quote that stands out to me. Cold-blooded benevolence makes us as uncomfortable as cold-blooded malevolence. Psychodynamic layers to altruism. So I would say broadly, there's healthy altruism and pathological altruism. So healthy altruism is what we would call generative altruism. If you look at lots of positive traits or lots of traits, there's a distribution in the population, and some of us maybe are more large-hearted or generous or compassionate than others. But there's also pathological altruism. So one example of that would be conflicted altruism, which I would say clinically manifests as ambivalence. Part of me wants to donate, part of me doesn't want to donate. Then there's pseudo-altruism, which is on the surface, it looks like altruism, but dig deeper and it's something else, like masochism or guilt, self-flagellation, suicidality, etc. Some of the things we talked about. Then there's proto-altruism, which is really sort of the altruism to somebody that your child or somebody you're genetically related to. Psychotic altruism, which we touched upon a little bit. From the perspective of neurobiology, Abigail Marsh from Georgetown University has actually done fMRI studies in which she has compared organ donors, what she deemed as extraordinary altruists, to psychopaths, to healthy controls. And what she did was she basically showed them images of people with fearful expressions. And then the fMRI imaging actually showed that in the extraordinary altruists or the organ donors, their amygdalas were hyper-reactive as compared to healthy controls. And with the psychopaths, they were hyporeactive. And their right amygdala volume was enhanced with the organ donors. And the volume was lower with psychopaths. So as we can see, there is some hardwiring, there is some neurobiological correlate to the way in which the brains of certain people might respond to the suffering of others. And this is some visual of that. From the evolutionary perspective, so when I was growing up, I had read this book called The Selfish Gene by Richard Dawkins that I really loved, and he talks about the idea of reproductive fitness. So I guess the basic idea is that altruism at the level of the group or even at the level of the individual or organism can be selfishness at the level of the genes. So the idea is that the gene is a replicator and it's trying to make as many copies of itself as possible. And if you look at something like the love of the nurturing that a parent does for a child, there's a lot of investment of time, energy, resources, etc. But what's actually happening is that the child, and again, not to take away from parental love at all, but at the evolutionary level, it's like the child has 50% of your genes. And so that behavior will get passed on to the next generation because that child that you have protected and nurtured will reach reproductive age and then will be able to pass on those genes and ad infinitum. So that's something to keep in mind. And game theory, actually, one more thing I'll say about the evolutionary perspective is reciprocal altruism. There's a lot of sort of cooperation and something that looks like altruism, but it's also sort of one person in a group helping somebody else, but then that person's also helping them. So in game theory, so have people heard of the prisoner's dilemma? So I see a few nods. So what it basically is the broad idea is that imagine that there are two prisoners, and if both of them tell on each other, then they'll basically get 20 years in prison. So they'll get a long time in prison. However, if both of them cooperate and say, take the blame, then each of them will get 1 year in prison. Now, what's optimal for both of them is, of course, to go free. And that can only happen if one of them sort of blames the other person, and then the other person takes the blame. So if you think about it strategically, each person certainly, would be benefited by the other person taking the blame and them blaming. But if both of them thought in that way, it would backfire. So the most optimal outcome is actually cooperation. And I would say, a practical application of this is if you look at a workplace or if you look at a residency program, for instance, if you don't help somebody else, you very quickly acquire a reputation of not being someone who should be helped either. And so, in a way, cooperation can also be a strategic, selfish move. All right, so Peter Singer, people are familiar with this very controversial philosopher. There was a New York Times interview. So he talks about the idea of the drowning child. So his idea is basically that, if you see a child drowning in a pond and you're passing it, most of us would not hesitate, even if we're wearing like designer clothes, whatever, to get into the water and save the child. But he says that it's not just the child that's in front of you. There are so many drowning children all over the world. And when you use your resources to not help these drowning children, like children that are starving in, towns near you or far away from you, you're actually, they're morally equivalent. So he feels like we have a moral imperative to channel our resources to help every drowning child around, right? And this is effective the idea is effective altruism. You have to be strategic and smart and clever about how you use your resources too. So that, yes, your resources are limited, but how can you help as many drowning children as possible in the most strategic and practical way possible? Wanted to reference also in terms of bias and countertransference that we have. Paul Bloom, who is a psychologist at Yale, has written this book called Against Empathy. And this is interesting because the idea is that empathy is like a spotlight and it's not rational, as one can imagine. And so the best example that I have of this is when I'm in the recipient review committee. Often, there are certain stories that pull at people's heartstrings more than others, and they can result in emotional reasoning and the allocation of resources in that way. So this is an important thing to keep in mind too, that there's bias and countertransference that's baked into the decision to be altruistic. Like people will say that, oh, I saw this flyer and this person has 2 kids and I have a kid too. And that's why I cannot imagine not being able to play with my kid. Just wanted to quickly talk about a few ways in which people solicit or get organ donors or facilitate organ donation. So have people heard of the organization Renewal? So Renewal is an organization that connects Orthodox Jewish donors and Orthodox Jewish recipients. About 60% of non-directed kidney transplants or altruistic kidney transplants in New York are attributed to Renewal. It started first in 2006. There's a lot of support. Non-medical expenses are covered by Renewal. There's a lot of support for the donation process. Also, even though it's not, there's not really sort of a mention of faith, etc., on the website. There's some mention in the sense that it's considered a mitzvah. It's considered like there's rabbinical endorsement of this act. It's considered a good thing to do. And in reference to that, I've certainly seen in my office people who say that, oh, my wife has donated, my mother has donated, and now it's my turn. So there is this little bit of a sense of social contagion. There was a survey of blood donors in the Netherlands from 2007 to 2014, and they found that donors were positively affected by donations made by other donors in the neighborhood. So I certainly in practice see a little bit of this, that it's almost like this is the default, this is the norm, that you do this if you're healthy. The Children's Hospital in Colorado, they actually had a wait list for their liver transplants that they completely eliminated by soliciting donors. And as you can imagine, going back to the idea of empathy being a spotlight, I would imagine that there were a lot of people, and when I read the article on this website, there was a story or an anecdote of a woman who said that, I have kids and I cannot imagine them needing a liver. So that speaks to sort of the emotional reasoning, and not that there's anything wrong with that. That's probably part of being human. The emotional reasoning that goes into altruism. Dove is an organization that connects people to veterans in need of an organ. I think most people recognize who this is. One of the most famous, this is Taylor Swift. I don't know if do people get the reference of altruism? So, okay, so this this might be a little bit of a deep cut of Taylor Swift. Yes. Yeah. So there is actually a lyric in one of her songs, Anti-Hero, in which she says that my my covert narcissism disguised as altruism, like some kind of congressman. So this is actually in a Taylor Swift song. And so I actually looked up if there were any studies, connecting narcissism and altruism. And there actually was a study of 286 adult volunteers looking at the relationship between the dark triad, which is psychopathy, Machiavellianism, narcissism, and altruism. And they actually found that there was a negative correlation, as you can imagine, between Machiavellianism and altruism, because Machiavellianism is kind of being deceitful, manipulative, etc. But what they found was that when you control for other dark traits in the triad, then narcissism is actually a significant protector of general altruism. So that is interesting. There is something about, I guess, the idea of like, I can help, or I am the one who will help. I would recommend, since we talk about pop culture, Confessions of a Good Samaritan. It's a 2023 movie which actually chronicles the living donation experience, non-directed living donation. Just a few more slides. I know I'm running a little behind time, but altruism and pain. So I thought that this was very interesting. There was a comparison of recalled pain memory between directed and non-directed donors. And this was from 2015 to 2018. And basically what they found was that non-directed donors at all time points, their pain recall was actually lower. They had lower analgesic use, they had earlier return to employment, and lesser interference in activities of life. And it's interesting because I guess one thought that came to mind for me was that this is the way the experience is framed, as a meaningful experience. But then the other thought that I had was that with directed donors, often there is a close relationship with the recipient. So you're still stressed about how the recipient is doing, etc. Whereas in non-directed donation, often, you can just focus on, I did it, I did my part. So just a hypothesis about this. Of course, I think many of you may be familiar with this one RCT, which was a single-site RCT done by Dr. DeMartini and Mary Amanda Dew, which looked at ambivalence and motivational interviewing. And basically, this is one of the good sort of pieces of evidence to support that lingering ambivalence is associated with poor psychosocial outcomes, and motivational interviewing, which, as we know, is a framework to address ambivalence, actually helps people. So they have fewer physical symptoms, lower rates of pain, fatigue, etc. Disparities in donations. So I'll just go through this very, very quickly, because actually we have a pre-recorded session that we did on disparities in donation, which really does a deep dive. But what I will say is that disparities in donation related to race can be conceptualized in one way as an epiphenomenon of systemic racism, because donation implies that you have to be healthy enough to donate. So a lot of social determinants of health, whether it's lack of food insecurity, lack of access to healthy food, socioeconomic factors, etc., can come to bear on your health, and you may not be healthy enough to donate. ApoL1 testing, so ApoL1 alleles, there is an allele that's been linked with a higher risk of chronic kidney disease, a host of different kidney conditions. And this is prevalent or more prevalent in people that are of West African descent, ancestry. And so this can be one of many ways to actually help identify and screen people who may be at risk, and perhaps, the informed consent process for living donation should be different. So just wanted to put out there that 27.8% of non-Hispanic Blacks that were awaiting for a transplant were they were there's a big disparity in the numbers. So it was 27.8 of those actually ended up, getting a transplant on the wait list. And in non-Hispanic whites, it was 47.2%. So there are certainly disparities. One way, among many others, to address disparities and to equalize them or to achieve equity is, of course, to make sure that people are not worse off when they donate. And so the NALDAC, or National Living Donor Assistance Center, it does give lost wages, transportation, lodging, childcare expenses, but it's also to US citizens and permanent residents. I know we talked a little bit about substance use in living donors, and I think cannabis is particularly interesting because we talked about the center variance. There's no impact on medical outcomes, but actually, a review of 757 living kidney donor candidates found that cannabis use was actually associated with a slew of other psychosocial risk factors, such as active psychiatric disorder, multiple psychiatric diagnosis, suicidality, etc. All right, well, we have to talk briefly about outcomes. So the RELIVE study is a very large study between 1963 and 2005 of 3 transplant centers, and 95% of these donors, it was a large sample size of 2,455 donors, they rated their overall donation experience as good to excellent. And as briefly mentioned, recipient graft failure was the only predictor of one or more poor psychosocial outcomes. The adult-to-adult living donor liver transplantation cohort study, or the A2ALL2, also looked at liver donors before and after donation, and they actually had low depressive symptoms, low anxiety symptoms, alcohol abuse. However, about between 4.7 to 9.6% of them actually did report impaired well-being at various time points. There is most recently the Rasmussen study, which is an interesting set of semi-structured interviews of 56 kidney donors, in which they actually found that people reported improved interpersonal benefits, time, health and wellness, financial benefits. And it's interesting because as I was reading the paper, one of the things that stood out to me is that 30 of these donors actually were in interdependent relationships, which means that a lot of these benefits were related to not having to care for their spouses as much, or reduce caregiver burden of the spouses that they donated to, having more freedom for travel, the spouses being able to help out more financially or at home. And my last slide is basically about gifting twice, or how much is too much. Zell Kravinsky is this billionaire who basically gave away the vast majority of his fortune and donated his kidney, much to the chagrin of his family, which brings up the question of, how much is too much? And of course, with him, there were sort of psychodynamic layers. There was a New Yorker profile of him, which seemed to suggest that he was very uncomfortable with the idea of he had acquired a lot in life, but he was very uncomfortable with it. It didn't sit well with him that he was so privileged. There are about 150 sequential liver and kidney donors in the United States, and there was a study that was able to look at 20 of them, and it was found that very, very intuitively, a positive experience with the first donation was often the driving factor for the second donation. And at the second donation, about 85% were non-directed. All right, so my conclusions, I will say that there are extraordinary altruists in the world. Of course, part of our role is identifying the difference between generative or healthy altruism and pathological altruism. But a good action can also be psychologically complicated, as you were mentioning earlier. And we want to protect but not over-pathologize, and always recognize that the ethical and clinical issues are often very deeply intertwined. Well, thank you so much, and hope to continue the discussion. And now I'd like to. Okay. Okay. All right. I'd like to invite Dr. Phipps.
All right, so I'm now what is between you and a break, it sounds like. So, good to see everyone. I'm David Phipps. I am both an addictions and CL psychiatrist who is mainly involved in transplant at Mayo Clinic. And oh, thank you. I clearly have fans in the audience. Appreciate it, Scott. So, we are going to be talking about clinically relevant substance use testing in the organ transplantation population. I have no disclosures to disclose, and I'll have my learning objectives up there for you, but we'll go ahead and hop right into the content. Now, whenever we have a discussion about talking about substance use and biomarker testing, it's always good to at least have a little bit of a discussion around rationale. And this particularly is from the American Society of Addiction Medicine consensus statement about the role of lab testing. Essentially, testing is a part of the evaluation, but not necessarily directly correlated to ensuring that there's a diagnosis of substance use disorder. Obviously, that's part of your clinical evaluation and history. And testing should not be the sole measure of an individual's use. And testing should be integrated fairly widely, both in the initial assessment as well as monitoring how well your treatment is doing. And testing is not punitive, rather, it's a tool to support recovery and provide motivation and reinforcement for abstinence, which really links with this concept of the fact that addiction is a chronic and relapsing disease, right? We know that just like other chronic and relapsing diseases, the relapse rates for addiction is similar to diabetes, hypertension, and asthma. And as we see with all of these diseases, we're going to at least have some universal screening. I mean, you probably get a blood pressure every time you go to your doctor's office. Probably the first time they see you, they at least should be checking your glucose. And so similarly, we're going to be universally screening individuals. Why? So that if something comes up, we can then dig a little deeper and have some diagnostic accuracy. Diagnostic accuracy is important so that we can be engaged in evidence-based treatment. And treatment, of course, decreases morbidity and mortality. When we're talking about addiction, we're talking about diabetes, talking about hypertension, both in the general population as well as within the transplantation realm. And also, we're going to be trending these objective tests because that's going to identify how good our treatment is for individuals. And when we take this approach, we say, well, how do we approach relapse then, right? Your blood pressure is doing well, then it's not doing well previously. We say, well, how can we better optimize your treatment plan? Not why is your blood pressure higher, right? How can we better optimize this plan to finally have the goal of increasing outcomes and morbidity and mortality rates? So the mindset is that screening is not insulting, treatment is not punitive, and the goal is to improve the outcome. And this matches fairly well with what the Psychosocial Ethics Committee work group recommendations for screening of substance use disorders in the transplantation population implies. Obviously, we want universal screening of all transplant candidates. And if there is a substance use disorder uncovered, then we want to be having ongoing monitoring of these individuals, as well as regular monitoring of individuals taking controlled substances, whether or not there's a substance use disorder. Informed consent, obviously, and judicious use of confirmatory testing, because there are many false positives and negatives pertinent to the transplantation process. And this is important because substance use is common in the transplantation process and it's influential to outcomes, not just with liver. I know that's the one that gets really popular when we talk about substance use disorders, but substance use has been correlated to all of the solid organ transplantations, and whether it be the primary cause of the end organ disease, whether it be a contributor to the end organ disease or an exacerbator of a vulnerable substrate. We certainly have some influence when it comes to substance use within transplant from multiple perspectives. And like I said before, addiction treatments improve survival. And so that is our final goal when we are looking at this lens of substance use testing. So with that foundation underneath us, objective data, testing allows us to have objective data, identify relapses, partner with the patient, enhance their insight, encourage treatment, and influence outcomes. So we're going to spend most of our time talking about alcohol biomarkers, but we are going to spend some time talking about cannabis and how to distinguish between new versus residual use, as well as some high-yield urine drug screen components as well, alcohol biomarkers. So, as most of you are probably well aware, there are both indirect and direct alcohol biomarkers. Indirect being things such as AST, ALT, GGT, you got your MCV, CDT, so on and so forth. These are all indirect because they're testing for the sequelae of substance use. As in, you have all these biomarkers, you put some alcohol on a hepatocyte, and it lyses and it increases and goes into the bloodstream, right? But as we're all well aware from medical school, eventually your enzymes are going to stop being created when you get into end-stage disease. And so there are multiple limitations in sensitivity, specificity, and many false positives and negatives pertinent to individuals in end-organ disease, which has really brought us more to the direct biomarkers. The most, one of the more famous ones that gets used more frequently is the urine ethylglucuronide, which is a phase 2 metabolite of ethanol. Detection window of 1 to 5 days, though its sensitivity and specificity is a little bit better from the 3 to 5 day mark. And it's not just a binary yes or no, has this individual used within the past few days. There are quantitative measures that are able to say this is likely how much this individual was using over those past few days as well. However, there are many false positives and negatives and limitations that are worthy to identify within the transplantation context. First off, you can have a true positive that is over elevated if the individual has renal impairment. You'll have a hyperconcentrated urine sample, and though, yes, I did drink, the amount in those 3 categories of that chart I just showed may have an over high true positive. Same with glucosuria as well. Very common piece. Many people have diabetes who are going through the transplantation process. And if you remember back to medical school and alcoholic fermentation, right, glucose is the first step of that. And if it's sitting in a cup waiting to be tested, it may go through that fermentation process, especially if there's already some alcohol in the system to where you may have, again, an over elevated true positive. Other limitations, someone may not be able to urinate. Kidney transplant, very common piece when we have on dialysis. And their false positives, the ethylglucuronide actually does have some vulnerability to extraneous alcohol use, such as excessive hand washing, hand sanitizer, Listerine use, so on and so forth. As well as bacteria. Having urinary tract infections sometimes can cause this alcohol fermentation process to be more expedited and have false positives. False negatives, quite a few, but the one I really want to identify there is some of these upper respiratory infections, which is why if you've ever actually looked at most urine ethylglucuronide testing, it typically should be an ETG with an ETS, ethyl sulfate, because some of these upper respiratory infections can influence the beta-glucuronidase hydrolysis process and cause a low or completely negative ETG in the presence of ethanol, but still give you at least a positive ETS as well. So a little clinical factor there that is worth identifying, especially if there's upper respiratory infections involved. However, growing in popularity is another direct biomarker called phosphatidylethanol, which I will verbally abbreviate as PEth in this conversation. PEth is a group of phospholipids that's incorporated into the membrane of red blood cells in the presence of ethanol catalyzed by phospholipase D. And essentially, you have a single ethanol intake, and you're going to get the peak concentration of phosphatidylethanol about 90 to 120 minutes after ingestion. It just takes that amount of time to get from the GI system into the bloodstream and incorporate into the phospholipid bilayer. The rate of PEth formation correlates with the ethanol concentrations, and with frequent alcohol consumption, the PEth accumulates in the whole blood and then slowly tapers down over time, to where we're about able to say, you know, there's different time frames, but really 28 days is one that we're able to really hang our hat on when we're talking about how far back a PEth can identify use of alcohol. One of the ways that I look at this as well is sometimes we say, you know, if there's a fire in this room and it caused smoke to get on the ceiling, and then we put out the fire, you're still going to have the smoke on the ceiling. So it's identified, yeah, there was a fire in this room. Does not mean that we actively have a fire going on in the room at that time. And it may take some time to clean off the ceiling and get the soot off of that. And like I said, there are time frames of identification, and we typically hang our hat on the 28-day mark. But notice the sensitivity and specificity is absolutely excellent when it comes to PEth, with some studies saying 100% in some of these, which is, I almost never believe anything that says it's 100%. But within that particular study, within the foci, it did have an 100% sensitivity as well as another with 100% specificity. And unlike the ethyl glucuronide, this is not influenced by hepatic impairment, by renal impairment, or dialysis. And there are really two prominent homologs of phosphatidylethanol. There's many homologs for it, but the two that are most clinically used are the PLP PEth and the POP PEth, which we call the POPE. And if you're curious of where that difference is, there it is right there in the little carbon double bond chain. Yes, our organic chemists love to change those chains. Essentially, the PLP PEth is typically used as a confirmatory test. So if you got a positive POPE and a positive PLP, yeah, there's been exposure to alcohol, absolutely. PLP does come with quantification and a numerical value oftentimes, but this has not been validated to fully equate to drinking patterns as the POPE has. And so if you're thinking of PEth and the numbers that are correlated to drinking patterns, you're probably thinking of POPE and that predominant homolog. And so we have three categories here that have international consensus of correlating to how much an individual was likely drinking over the past 28 days. And the cool thing is, because this is a blood test, this is far less susceptible to extraneous alcohol use, such as excessive hand sanitizer, mouthwash. And the studies where they looked at that and had excessive use, typically it reached about 12 or 13. And so some tests do have a cutoff of 10 being, quote, positive. But if we use these categories of less than 20, indicating possibly abstinence, if not very light levels of drinking, then it allows for some of that correlation to be better identified. Which brings us to a study that I recently did. This one is actually getting one of the Dorfman Awards. So thank you. This was a study where we said, okay, well, how useful is this in the liver transplantation process? And we said everyone's going to get phosphatidylethanol. And it went for about 1.5 years of the time frame of the study. We were still doing it clinically. But the study itself went about 1.5 years. And we said, all right, so did PEth identify a discrepancy from their last use date or how much they were drinking? Would this have been similarly detected with the urine ethyl glucuronide? And did it matter? Did it influence our clinical decision making? And over this time frame, we had the equivalent of about a positive PEth every 2 weeks or so. And what we found with that is that when the PEth was positive, the majority of the time it identified some form of a discrepancy of their subjective last use date or their pattern of use. Almost 50-50 of it not being identified by an ethyl glucuronide, and the majority of the time as well, this influenced clinical decision making. As a specificity there, it really didn't change too much of how much high-risk candidate we thought they were from a psychosocial perspective, but it greatly influenced our chemical dependency treatment recommendations of whether or not to go to treatment or escalate treatment. Because again, chronic and relapsing disease, how do we better optimize your treatment plan? And of course, to equate to allowing the individual to be in treatment, obviously this would have some high influence on the decisions to defer or deny in the vast majority of cases where it was positive and influenced the clinical decision making. However, any new kid on the block talking about really exciting biomarkers, we always need to talk about limitations as well. And obviously, when we're talking from a biochemical perspective, inter-individual differences in the pharmacokinetics of PEth synthesis and elimination, phospholipase D activity, certainly can have some changes. However, obviously, we don't have pharmacogenomic testing to identify your phospholipase D activity. This is more to identify in the future, in my conversation, why this may matter. Because really, one of the biggest false clinical positives that gets discussed the most is this concept of blood transfusions. So imagine for a minute that you live in a college town and the kids there are, donating their blood for their beer money, right? And they obviously probably drank within the past 28 days. They donate the blood and you have a positive biomarker, understandably, in their donated blood that was exposed to alcohol at one time over the 28 days. You then transfuse that blood into a transplant recipient and you have a true laboratory positive because the blood was exposed to alcohol, but it's a false clinical positive because the individual did not actually drink. And PEth can stay positive within a little bag for a red blood cell for months because the turnover rate within a bag versus within an active body is very different, and which is why we have a 28-day time frame within the body, but 3 to 6 months possibly within a bag. And if this interests you, I would consider testing your institution's blood bank. We tested ours at Mayo Clinic and found that 30 to 50% of donated blood would have a greater than 20 positive PEth. And so in the process of having transfusions, very common within our transplantation population, there may be some value in identifying a pre-transfusion path and a post-transfusion path. The only false negative that we're aware of right now is if someone drank during that time frame right before getting their blood drawn, right? Like they're in the lab, parking lot, they drank real quick, ran in, took the blood before 90 to 120 minutes. That may give you a false clinical negative. However, also doing an ethylglucuronide at the same time would identify that, which is why the recommendation is not just to move to PEth, but to do both of these at the same time. Ethylglucuronide and phosphatidylethanol will likely identify quite a few things, especially when combining those sensitivities and specificities. The last thing on the slide here that will transition us to the next slide is to be cautious about time frame and level minute absolutism. What in the world does he mean by that, right? So in essence, when we hear about these numbers, and we say 28-day look back, when we got all these levels, right? A lot of times, especially individuals who are not well aware of mental health comorbidities, may find that they're being a little bit absolutist, right? Well, this person said they drank 29 days ago and their path was still positive. Or well, they said they were drinking this much and that doesn't seem to correlate within this chart that you showed there, Dr. Phipps. We need to be sure that we're taking a little bit more of a realistic point of view and better understanding the process of PEth to better understand how these levels correlate. So first off, the PEth half-life, as in literally what it takes to go from 100 to 50, is 3 to 5 days. But the variability of phospholipase D activity could be up to 10 days. And remember that it takes 5 to 7 half-lives for something to completely exit your system. So on average, with population studies, yes, 28 days is the good time frame. But with this said, you could have 70 days of a positive PEth. And it's good to be aware of that so that we're not using absolutism on this 28-day time frame. Similarly, the way that PEth is eliminated, the stairwise up increase and then the slow taper off, mathematically, if you're drinking a lot and you max out the PEth test at greater than 2,000, then it's probably going to take longer to completely trickle down to negative than someone else who may have a 25 and it trickle down to negative. And so there are certain situations where the 28-day time frame is a variable time frame to where we need to have clinical correlates when it comes to this. Again, going back to saying the substance use testing should not be the only measure of a patient's use. And when we look at it from the level absolutism as well, one of the things I want you to notice about these charts is that as the PEth gets higher, the variability of the test number is going to wave much more. What do I mean by that? That means it is not proportional a difference between level of drinking at the lower levels as it would be at the higher levels. So if someone's drinking at a 25 rate, that is drastically different than 225. That's literally a difference in the categorical allotment of drinking. However, if we take the same 200 difference and bump it up to 600 versus 800, that is not necessarily the same numerical value proportionality difference because there's more variability when it gets to the higher levels. And so saying, this person's likely drinking far more because they have an 800 versus this person has a 600, that difference, though numerically 200, is not the same as a 20 versus a 200. Moving on to cannabis. So a few basics to lay the foundation for this part of the conversation. The most common assay for testing for cannabis is urine, though there are gas chromatography and mass spectrometry that are a little bit more specific. But all of these tests are typically using the antibody target of carboxytetrahydrocannabinol. There's a few false positives and false negatives that are pertinent to transplant, but this is a pretty hot topic and they're regularly increasing the sensitivity and specificity of these tests. So it may be good to ensure you know what your specifics are for that. But the common industry cutoffs are typically between 20 and 50 nanograms per milliliter, with the most common being 50. However, these more sensitive tests are picking up things extremely low values. We have one that is as low as 3 nanograms per milliliter, and that is obviously going to be very different for tests that are only picking up things at 50, right? However, these levels are subject to fluctuate based on level of hydration and kidney testing. And the detection limit is pretty variable. It could be months depending on someone's history of using cannabis. Where marijuana is lipophilic, has a long elimination half-life, and it can be detected a long time after stopping use, depending on how frequent they're using, how high of a dose they are using, and how long they have been using. Which brings us to the dilemma. Well, okay, hold on. So marijuana testing is becoming more sensitive and having lower cutoffs. Marijuana can stay in the system long after stopping. And these carboxy THC levels are subject to fluctuate based on hydration and kidney function. Therefore, we cannot rely on just assuming that the number is lower and thinking that that means that it's trending down. We actually have to correct for their hydration status to properly identify if someone's marijuana or THC or CBD levels is truly going in a downtrending manner. And so when we talk about more high risk and high stake situations where we told someone, hey, you need to stop smoking cannabis in order to be considered for transplant, and then they come back in and it's positive again, and it hasn't changed very much, or it's only slightly lower. Well, is that new use? Or is that just adipocyte secretion? How do we separate that out? How do we say, well, is this new or is this residual use? Well, it's all about ratios. So first off, you need to properly correct for their hydration status, which is quite simple. This is called a normalized ratio, where you take this THC level and you just divide it by the creatinine. And then you say, all right, so the second collection normalized ratio, I then divide that by my first collection's normalized ratio, and you get what's called a decision ratio. And this number can then be compared to validated ranges based on time frame between the two collection points. And so the study that I'm about to reference here was one in a controlled environment on a research unit to where they gave individuals cannabis and then serially screened and correlated what the value should be if you are properly correcting for your hydration status. And essentially, you do those calculations, you say, okay, so the row that correlates with the time frame between the two collection points, I look at the maximum column and identify is my patient's level higher or lower than that? And if it is higher than that maximum point, that is highly indicative of new use, because literally everyone in that validation study had less than this maximum number based on the time frame between their use patterns. However, if you're lower, move over to the 95 percentile, and you will find the same concept. 95% of individuals in that study had less than that number between that time frame. And if you look closely, those numbers are fairly different and sometimes magnitudes different. And so some people solely go to the 95 percentile, but there is a little bit of area between 95 percentile and maximum that is worth identifying. So you calculate the ratio based on hydration status, you then get a decision ratio, you compare it to the chart. And once you do that it kind of is overwhelming when you hear it from a mathematical standpoint. Once you do this a few times, you'll quickly say, oh, yeah, there's no way that's going to be there. And so it's a good thing to practice, especially when we're talking about math. So for time purposes, I put my summary first of this section, just in case we needed to be a little more efficient with our time. So few quick points about the urine drug screen. One is get confirmations. There are many false positives and negatives that are pertinent to transplant. Substances do not go backwards in their metabolic pathway, and so being aware of metabolic pathways of certain substances is very important. And be aware of industry allowable pharmaceutical impurities. That'll be something we'll discuss. And concentrations do not always properly correlate to dose outside of alcohol. So, busy slide that I'm not going to read to you. The basic point that I'm going to identify here is that other than cannabis and PCP, most of the substances in the urine drug screen are only identifiable for a few days since their use. And so we need to be aware of this when we are talking about the utility of urine drug screens when it comes to substance use disorders that are not based on alcohol, cannabis, or PCP. And there are many false positives and false negatives that are available. So getting quantification and clarification is very important instead of just the presumptive positive urine drug screens. And notice that synthetic stuff, like the synthetic cannabis and the synthetic cathinones, which are the bath salts, typically are not identifiable by our average urine drug screens. I'm going to show a few breakdown pathways here. There's an interesting fact about selegiline that it actually does break down into methamphetamine and desmethylselegiline. So if you see someone who has a true positive methamphetamine screen and they're taking the selegiline and have the MSAM patch on, yeah, that's one of the metabolites of it. However, I'm including this breakdown pathway to also identify that things do not go backwards in the metabolic pathway. So if someone's taking an amphetamine salt for ADHD and they have a positive methamphetamine screen or an ephedrine screen, well, things typically don't go backwards in those pathways, and we can use concentration ratios to identify parent versus metabolite compounds. Similarly, from the benzodiazepine perspective, our urine drug screens are getting a little bit better, but the general traditional urine drug screen really only tests for diazepam and its metabolites. And so what that means is that an individual could be taking some of the most common benzodiazepines, such as alprazolam, lorazepam, and clonazepam, and not be positive. I can't tell you how many times I've been asked if I think that someone's selling their benzodiazepine because they say they're taking it and their urine drug screen was negative. Well, yeah, that one that you ordered didn't test for those. And so sometimes identifying that awareness is a helpful component of some distress tolerance for the team, especially. From an opioid perspective, I also included the breakdown pathway for your reference in the slides. And so notice if someone is taking hydrocodone, we shouldn't be noticing backwards in the process to codeine or morphine. However, there is a concept of pharmaceutical impurities. What in the world is this? Well, when you are in a pharmaceutical company and you are creating these medications, you're going to have some crosstalk between the different slats that you are using to create medications. And the pharmaceutical industry is extremely regulated. And so greater than 1%, no, you can't sell that. You cannot call that or label that of what you're trying to make the medication. However, there is an acceptable pharmaceutical impurity of less than 1% in the industry, which means that we may find that if the concentration, someone is truly taking an opioid and there is a concentration of less than 1% of the total concentration of opioids, that may be a pharmaceutical impurity. This has actually been fairly well documented, which is why I have a chart here. And notice that hydrocodone there can have a 0.15% impurity with codeine. And that's a fairly commonly identified piece. And so though things don't go backwards in the metabolic pathway, there may be things within the metabolic pathway that look backwards, which is why the concentration is important when identifying parent to compound ratio. This isn't as well identified in the stimulants, but this is a component that is available to be aware of in stimulants. And so we internally tested our own Mayo Clinic pharmacies and found that our stored amphetamine had about a less than 0.5 impurity with methamphetamine, which again is well less than the acceptable impurities. However, I know many times in the transplantation context where someone was taking ADHD medication and they were found to have a confirmed positive methamphetamine, and the team panicked and we're like, oh, have they relapsed? Is there a substance use disorder we didn't identify? But if you look at the concentration variables, well, yeah, that's like less than 0.5% of the entire stimulant load within this urine drug screen that is likely a pharmaceutical impurity. And again, clinically correlate. The substance use testing should not be the only measure of a patient's substance use. The last thing that I'll mention about concentrations is that if you were an expert on the stand and they were asking you, what substances can we absolutely quantify dose based on their concentrations? It's alcohol. That's it. And so can someone say, well, is that opioid qualification 20 milligrams of hydrocodone or 10 milligrams? No, there are way too many pharmacokinetic changes that intertwine with this answer. And so concentrations cannot reliably give minute interpersonal dosing specificity outside of alcohol. So a few inappropriate things that I've seen people do is, well, this person must have more panic attacks because their benzo level is higher than it was previously, so they must be taking it more frequently. Or I think they're using their oxycodone too much because the level in the hospital versus outside the hospital is higher. Or you know what, this one is using more cannabis than this one is because their levels are that much different. No, there's too much intervariability to identify specificity of dosing when it comes to concentrations outside of the alcohol biomarkers. And these specificities become even less accurate when you have things like metabolic changes and elimination difficulties, such as individuals who are in the organ transplantation population who are an end-stage organ disease. When it is appropriate to use concentrations is using ratios of parent compound to metabolite to identify if we're going down a metabolic pathway or not. It could support alterations in CYP metabolism as well, and using the concentration percentage like we talked about for impurities. But also, I think clinically it makes sense if you have a massively large concentration and the patient is describing massively small amount of use, okay, that may be a discrepancy. Let's use some provide illicit motivational interviewing to identify, what is your understanding of what this test means? And yeah, that one little puff you said you had 3 weeks ago, but you maxed out our lab at greater than 1,000. Okay. that probably doesn't correlate. So again, though we can't say the exact dose of marijuana this individual was using, it does still have clinical value when it comes to extremes oftentimes. I love summary slides, and so I always give summary slides. And this is available for you in the slide deck. More than happy to answer questions at the end and to be involved with the cases that we have.
That's like a 12-minute break. I took away 3 minutes. I was told to be 15. So let's 12-minute break. We'll come back. Then we'll have another hour. Then we still have an hour for discussion. Let's wait. Okay.
Yeah, yeah. I did. That's. That was very, very. One thing that really happened at some of that I was like, as you were talking about, put it up there, I was like, he's so good. I'm wider.
But also 33 minutes.
My slide deck is wider. there wouldn't be more people saying that.
I know, but I know.
Said it.
Yeah, it was like, what is that?
He sold it, yeah, to whatever, Miami Dolphin Stadium. That's like what
And then I
makes it-
told them they had to know they break everybody. I'm like, you go. How many people? I love the song. So like, I think, and they're like, no, this like, this is like, wait. So, yeah.
Lost.
I'm just fine, I was like, I'm like, so, oh, yeah, no. And he knows it, because he actually great. That's the problem. We tried to get it clear. And also get it at the same time. It's not this workshop, it's all done out of the third. I'm like, come on, God, we feel like you want. Or they think you can stand in your own world.
There you go.
Being proud. It's gonna happen.
Well, maybe we'll have people.
Oh, oh, very well, very well, you have to be.
If it's more,
Yeah.
professionalism goes out. Yeah, you know.
Like, you know.
Talk like this.
Yeah, so I mean, I was.
Well, they put our train on.
Oh, people are gonna.
Covered from the street, and I
Well,
was the street.
Yeah. I did not, I was. It's the humidity. Right, I was not in distress, right, because the most about it, so I have to work hard to read, but it makes sense in the context, because I'm like running here, and I know this is an answer, this is, I thought it was a good idea. Yeah.
People are very lucky out there. And. or like-
Oh,
all the crap and all.
air conditioning.
All those that had to do, those that. That commercial.
Yeah.
You were back.
Yeah, she's like. I'm like, but if you see.
That's why.
She knows it.
That's right,
She knows it.
that's
It was
right.
like, okay.
I don't know how I still my. Yeah, that's how it is.
Very appropriate. There's three margaritas. Right now. I feel like I'm listening. I mean, I am talking about alcohol. They're very appropriate.
Yeah, with the monitor being here, she'd be like,
Yeah, like, what are you guys doing? No, well, yeah, that's probably a bunch. That's gonna be fun, right? Right. Okay. All right. Have everybody seen, I think, two more people, right? There is so much distance. Yeah. I mean, there are three margaritas.
Wobbly. Hi, everyone. My name's Filza Hussain. My first task was to not fall flat on my face as I come up here in my heels. So I think this is going to be a rip-roaring success. I'm going to talk about alcohol liver disease and early transplantation and management. And we've all been doing this. We're a small, intimate group. We're not going to go through the didactics of all of it and the history of all of it, but really kind of think about some of the juicy points that we do get to chew on very frequently, and what do we do and where do we go from here? I have no relevant disclosures, and basically I am going to start with a brief outline of the background of early liver transplantation, just so that we can have some anchoring and some structure, and then talk about selection of candidates and what's new there, thinking about patterns of relapse and things to watch out for, and then what do we do for management? How do we think creatively? So as we all know, and my kind of love affair with all things transplant started because of Dr. Hafliger, who's in this room right now. And, you know, as I started working at Stanford, I kind of hurtled into the world of liver transplant. And right as I started is when they were developing their early liver transplant protocol. And so that's kind of my history with this. You know, I was a baby when I started, and I've now kind of grown 7 years later. And so very kind of mindful of the Franco-Belgian study that showed that these patients who have high mortality risk, high MELD scores, it is unethical not to offer liver transplants to them, especially in carefully selected patients. Initially, there were a lot of moans and groans about this. We were all very reticent to change. We were anchoring on the 6-month rule because it was concrete and not nebulous. And I remember attending my first meeting as a transplant psychiatrist 7 years ago, and really kind of picking up on the vibes, and the vibes were not good. Oh my gosh, this is terrible. And took some of that with me to Stanford. And over the next few years, actually things changed even more. And my sense is now we're getting even more and more permissive. And whether we like it or not, early liver transplant is a thing. It's here to stay. And the sooner we kind of think about how best to take care of this increasing patient population, the better. We as CL psychiatrists, I think, are uniquely poised to take care of this patient population. I know that our addiction medicine colleagues like to separate mental health problems with addiction problems. It's the same organ. There's so much comorbidity. I don't know how we make a case for that. So in my mind, we take care of the holistic health of our patient, and we as CL psychiatrists are very well positioned to do that. There's been some interesting pre-evaluation things that are happening in this realm. We do have celebrities in our midst right now, Dr. Winder being one of them. I'm going to touch upon some of his work later on as well. But there's been some nomenclature changes that we should know about in the liver transplant world, right? We don't call it NASH and NAFLD anymore. We call it metabolic dysfunction associated liver disease. And what that has done is it's opened up certain subcategories like MET ALD, and we all know these patients who have metabolic issues, have been drinking, that accelerates things. It allows for the language to actually speak to our patients about this, and so that's really important for us to know about. There are models of care which are aimed at prevention, where being co-located as a CL psychiatrist in the pre-transplant realm, in hepatology clinics, is a very helpful strategy, right? Think about the number of people in the United States who have alcohol use disorder, talking in the millions, and think about it as a public health issue. So really kind of thinking about integrated behavioral health within a subspecialty can be pretty unique. I'm not going to talk much more about that, but I am going to talk about insight, because that seems to be the phrase du jour and very important. And I'm going to talk about some tools to predict relapse, and then care for these patients, what's happening around the country. And then I'll talk a little bit about what I've been doing at Stanford. So here are the ground realities. We know that alcohol use disorder is a relapsing remitting illness, right? So once we say there needs to be abstinence, some of us tend to believe, well, we've told them why it's important to be abstinent, so it's not going to happen, because they're also saying it's not going to happen. But the reality is relapse rates can be anywhere from 8 to 40% in this patient population post-transplant. And you see that wide range because there's inconsistencies with how we actually define relapse. So whether we're talking about slips or persistent, consistent alcohol use. The other thing that I'm finding a little alarming as I'm working through all of this is our hepatologists are becoming very comfortable with being more permissive, right? So yeah, this is somebody who's a little high risk. They might have a slip or two, but we think they deserve a chance, right? That's usually the narrative. And when I say, well, when you look at their mortality risk, it's actually high, we're going to give them 5 years that they didn't have, right? That's usually the counter argument. And I think we need to equip ourselves with counter arguments to that counter argument. They talk about how there are other indications for liver transplants, which are relapsing conditions, and alcohol use is similar rates, and hence it's acceptable. And they will also say, well, patients do drink. It's important to note, though, that those who have alcohol liver disease, alcohol-associated liver disease, do tend to drink more when they do drink. So that's something to keep in mind. So why do we care? Why not just be like Oprah and say, you get a liver and you get a liver, everyone gets a liver. And certainly after last night, that's what I feel like saying, right? Because who cares? What's the big idea? But let's not do that. Let's recenter ourselves and think about the fact that there is still a discrepancy, right? Between the number of people who are on the wait list and the number of organs that are available. There are we are making headway into decreasing some of those by exactly like Dr. Sher was saying, using DCD livers, DCD organs, using extended criteria organs, but there still exists that discrepancy. We still need to be mindful of who's going to be a good steward of this limited resource, right? And what we have seen in the Accelerate AIDS study, which has been quite instrumental in learning about these patients and their outcomes, is that there is sustained alcohol use is a strong predictor of mortality. There are other studies showing what happens. And the key point that I want you to remember is that the 10-year mortality is high when you go back to drinking, right? So if little Johnny, not little, but Johnny comes to your care, he's needing a transplant, he has acute alcohol hepatitis, he's 36 years old. Great, we've given them 5 extra years. He's going to die at 41. Great, we've given them 10 extra years even. We don't care if they have a relapse here or there. It's okay. They're going to be very young as they die, right? So we need to put it in perspective for our colleagues and for our patients. There was a consensus meeting. Again, Dr. Winder was part of that. Like I said, we have celebrities here. And so they really kind of boiled it down and gave it more structure, right? We needed guidelines. We as physicians thrive on guidelines. Otherwise, it just feels really uncomfortable. And so one of the key take homes was insight is super important. But what really is insight and why is it super important? It's about knowing what your illness is and knowing what to do and how to treat it and what your trajectory is going to look like. And if you think about alcohol use disorders, you're pickling your brain in some pickling liquid for years and years, and then you're wanting your brain to make appropriate decisions and have good insight. And then you kind of throw in some spicy mental health issues as well. And it's a recipe for some impairment and insight. Yet we are asked every day to go in and evaluate these patients in hours, right? Selection meetings tomorrow, they've just hit our door today. They're super sick, their MELD is super high. We need your answer by tomorrow. And there's this pressure because these patients are super young, they have young families. Just as we speak, I have an email in my inbox right now saying, can you review and see if we need to transfer this patient over? They're 31 and have a 3-year-old kid. Not relevant to what I do, but they always will let you know. In fact, there's actually pictures of the family in that email. I kid you not. Yeah, it's wild. And so we really need to kind of think about how do we measure this? And not only how do we measure this, I think we as psychiatrists are still fairly reasonably equipped to talk about and think about insight, and our gut informs us as well as we see patients. But how do we help translate that to language that our other transplant colleagues are going to understand? And this is something that happened with the CIPAT, right? It brought some structure to what we do and made the surgeon comfortable because it gave them a number at the end. And when I say it's a CIPAT of 57, now that holds weight and they know what I'm talking about. And so there's hope that we're able to do some of that with this nebulous concept of insight because we've all said it's so important. Dr. Winder and his colleagues did a literature review, and what they found was there's really lack of standardization. And how do we operationalize this context? So it's great that it's in the guidelines, but what do we actually do as clinicians? And there's also a lot of focus, as we tend to do, on the biomedical aspect of it because psychosocial aspects of things makes us so uncomfortable. And there are existing tools, but these aren't tools that were made specifically for this patient population. And this patient population is unique, right? And these tools are older and they use language that is stigmatizing, and that just makes our job even more challenging. And so what did Dr. Winder and his colleagues do? They rolled their sleeves up and they decided to make a tool of their own. And not only did they use their own clinical experience, but they also interviewed experts in the field, and then came up with a list of questions that are important, and then road tested that with a small sample of patients and came up with the revised 36-item tool. I will direct all questions related to that to Dr. Winder. I don't feel equipped to talk about that. But I think there is, like, this is where some of the meat is at, right? Like, this is going to be important. This is going to equip us again with language that people will start to understand as it's widely adopted. Even in its preliminary phases, people are reaching out and saying, when can we use it? And currently it's being validated with larger numbers. So watch this space because it's going to be awesome. Wouldn't it be nice if we also had other things that could help us speak coherently about how we risk prognosticate, right? I really function a lot with my gut and what is my gut telling me, but then how do I tell the surgeon that, right? He's just going to look at me and say, what are you talking about, woman? But if there's risk factors, and they certainly are in the literature, I can really kind of talk about how those portend poor risk prognostication. And so older age, and in this patient population, when we say older age, we're really talking about people who are older than their 40s, 44, 38 to 44. Anything older than that is older age. Supportive family, protective. Risk factors being the severity of their alcohol use disorder, right? So if they've been using a lot of alcohol, if they've been to rehab multiple periods of time, if their abstinence prior to them showing up is short, or if they've had other comorbid substance use disorders, they've had criminal or legal issues, DUIs, multiple ones, if they were told about their liver disease yet were having a hard time quitting, really talks about the severity of their alcohol use disorder. And those portend that these are going to be people who will have a relapse. Would be nice to have a crystal ball, but as physicians, I think we would take a tool any day. There are tools that exist that think about relapse risk stratification. These are available for you. I've made little notes under the slides so you guys can review them. There's multiple ones, some of which were conceptualized for this particular task, and others like the PsyPat that actually weren't conceptualized to think about risk prognostication for specific domains, but they have been used by other centers. So UPenn used it, the PsyPat, to see if it can prognosticate relapse to alcohol use. They used a cutoff value that was much lower than what's acceptable at our institution. So our cutoff value internally is 40. Anyone over a PsyPat of 40 has a lot of psychosocial risk factors that need to be worked on. They used a cutoff value of 21 and found that, that the PsyPat does predict relapse to alcohol use disorder. So there's some utility of these scores. When I first started doing some of this work, I took the HRAR and tried doing that. But I think all of us will find that even though there's a plethora of them, the challenge is, and you will find this in literature as well, their positive predictive value sucks, right? So their negative predictive value is great. They're able to tell you who's not going to drink, but they're not able to tell you really well who is going to drink. And that's really where the money's at. So that's what we need to do. Exactly. It's a relapsing remitting illness, for sure. Yeah. The challenge, I think, Dr. Hafliger, is really identifying who to direct your limited resources to. In an ideal world, in my opinion, I think we're doing a little bit of speaking from both sides of our mouths, right? Here's what has happened with these early liver transplants. We evaluate them when they haven't yet hit the 6-month mark, because although we're saying the 6-month thing is no longer a thing, we're actually still using it. And the moment I say, well, this person doesn't really qualify for our limited sobriety pathway, magically when they hit 6 months, they're now hitting 6 months. So we're doing both, and we have limited resources, right? So in a place like California that seems to be on paper like the golden place for psychiatry, our patients have such a hard time accessing substance use care that if we were to develop programs, we should absolutely develop them for everybody. But right now, for example, and I'll talk about this in a little bit, my time is limited. If I can identify who really needs the most scaffolding versus those who don't, it'll be helpful. And so that's where some of these tools can be super helpful, but we don't have really good tools right now. It is the age of AI, and AI is soon going to be the answer for everything until it, kind of stabilizes again. The pendulum's going to swing this way, then it's going to swing that way, and eventually it'll be back in the middle where it belongs. There are colleagues who are thinking about using AI models to see if they can improve the positive predictive value of some of these tools. And there's a great paper by Lee and colleagues from UCSF that is talking about exactly that. They were able to use a small sample size, put an AI model there, and actually did improve positive predictive value. But with the caveat, all of this is new. There's going to be more nuance. It needs to be fleshed out more, et cetera. So not yet ready for prime time. Speaking of Lee and colleagues, I do like reading his papers because they actually really kind of boil down to what is important. And what he did here was him and his colleagues looked at the Accelerate AH data, looked at 153 patients, and eventually analyzed 146 because some of them didn't make it after transplant, 7 of them died. And their patient demographics were pretty similar to what we see nationally for these early liver transplant patients, younger, males, typically Caucasian, and they do have private insurance. Their median abstinence before their liver transplant was 53 days. MELD scores were high. Interestingly, in this cohort, 51 of them showed overt hepatic encephalopathy, and I find that interesting because we actually use that as an exclusion criteria in our cohort. We have to be able to have a conversation with the patient because we're evaluating their insight. So if I can't evaluate that, I'm not able to comment on it. But they included those patients, and what they really found was that cumulative survival after 1 year. And this is what we found in the Franco-Belgian study. This is what the Accelerate AH study showed. The 1-year survival rates are the same, right? So if I wanted Johnny to live from 36 to 37, we're good, right? But that's not what we want to do because then we think about the ethical aspects of transplant and we think about utility and we think about all of those things and things get confusing. What they did was they identified 4 different patterns of alcohol use. And this is super helpful because I actually use this and show this to my patients and put it in terms that they can understand. So Johnny, if you want to live till about 38, you can go back to drinking after transplant. However, if you want to be able to walk your daughters down the aisle, which is what you're telling me you want to do, abstinence is the way to go. And when I show them the Kaplan-Meier curves and explain to them what it really means, you will notice that after the first year, all of these patterns, so abstinence, early relapse and heavy drinking, some abstinence for a while, and then not so heavy drinking, and just early kind of relapse, but not heavy drinking, right? So there's people who are completely abstinent. There's others who are able to remain abstinent after the liver transplant, but eventually go back to some drinking. There's others who are not able to maintain their sobriety, and they're either doing lower levels of drinking than they were before, or they're back to the same patterns. People who are not able to maintain sobriety, as we would expect intuitively, because of what happens to their graft, their survivals are pretty poor. And so really, if you want to think about 1-year survival data and 3-year survival data, that's what's impacted the most. And I would say, do you want to just see your 39th birthday, or do you want to, maybe live on beyond? We don't have data for beyond right now, right? So they actually, Lee and colleagues used computer modeling, and what they were able to show was right now, average lifespan is about 15 years for those that are able to maintain sobriety. But when they model it out, 20+ year survival data looks great for those that are abstinent. And when you tell patients that, they're probably going to forget because they're pre-transplant and they're super sick. But then I go back to it post-transplant and kind of remind them of that and reinforce it. The other thing to talk about is that treatment exists, and unfortunately, nationwide, we're not utilizing treatment for alcohol use disorder. We're certainly not using medication-assisted therapies as well. And there are medications that exist. Naltrexone, there's just recently been a meta-analysis showing that it's actually not as bad for the liver as we are used to believing. And so we really need to feel comfortable with that and prescribe this more often. Camprosate can be limiting if their kidney function isn't great, but can be a great option. Combining them can be a great option because they do have different mechanisms of action there. And then disulfiram, although the adherence to disulfiram is not the best. There's others as well, but they're second and third line. They're not as efficacious. I've certainly had some more response with baclofen than, say, gabapentin or topiramate. There are behavioral therapies, CBT, and motivational and enhancement therapy having the most robust evidence. And again, as intuitively and empirically, we find out with the combined trial, when you combine those two modalities, there's going to be better outcomes, right? And that's really where the key is at. Exactly like Dr. Hafliger saying, we know it's a relapsing remitting illness. Let's give them the treatment for this illness, just like we do for diabetes or hypertension. And there are people who are doing some interesting things around the country. I think psychiatrists are recognizing and are at the forefront of doing some creative thinking. So Dr. Goswami, who's part of our transplant SIG at UPenn, has developed a virtual IOP. These patients are so sick, they can't go to traditional IOP. And she's like, no problem. We have a virtual option for you, 12 weeks. You come, you do this. And the completers, people who completed this program, have lower relapse rates. They were also able to then develop more of an alumni group and have more support for these patients. Similarly, there's other people who are taking that integrated behavioral health model and embedded care and really looking after these patients. And surprise, surprise, they have lower levels of sustained alcohol use. 3.5 is the lowest that I've seen in the literature so far. And what they're basically saying is we're providing them with support, we're helping them with therapy, we're helping them with medication, we're treating other things, and there's better access to that care. There's a little bit of a modification of that we're doing at Stanford. So like I said, we started developing this in 2018. It's a living document in our mind. So as the field changes, we have to be nimble and incorporate things. So this incorporates the Dallas Consensus Guidelines. It has cutoff scores. I was a little bit more strict initially, where I had internal score cutoffs for alcohol use disorder and substance use disorders. But then I felt a lot of resistance from our hepatologists a year into it, and they did away with that. But a SIPAT of 40 or less is an absolute requirement, and I need to be able to interview them. And ideally speaking, I need them to let me know ahead of time when such a person is coming in, and then I will see them serially. So I will see them in the hospital multiple times before I'm able to say that I'm ready to present. That's been working out fairly well. I'm able to see them at least 3 times before I'm presenting them. They do presentations on Tuesdays and Fridays, so I really kind of, ask them to present them on Fridays instead, and that kind of works a little bit better. Our numbers are similar to what national numbers suggest. We certainly saw a swell in the acute alcohol hepatitis numbers during the COVID pandemic, because people were at home and they were isolating and they were drinking and there was nothing else to be done. But those numbers have petered off. But as you can see, the number of transplants that we're doing is steadily increasing. And there's constant conversation about increasing those numbers further. And there's a whole kind of, dynamic there that we can get into, but, it's a whole another can of worms, and there's financial motivations there, and there's whose list is bigger than others, and Freud would have interesting things to say about that, but we're not going to go there. The LSP referrals have kind of stabilized and plateaued. Unofficially, I have numbers for 23 and 24, and they're in that 40 realm. So we're getting about 40 referrals a year. We're transplanting less than half of them according to the limited sobriety pathway. So far I have 88 patients that have been transplanted in the past 6 years under this protocol with an average PsyPAT score of 32, average length of sobriety just under 3 months. The majority of them are white men with an average age of 44. And, initially I was really kind of patting myself on the back. So what they've done is they've embedded me, they've bought some of my time, 20% of my time to see these patients. All of them that have been transplanted under the limited sobriety pathway get to see me for at least a year. And that's official, but unofficially I will see them whenever I need to see them. And so I was really kind of chuffed, right? Because the relapse rate was about 11%. And I was like, I'm doing such a great job. And then we realized we're just not catching the pets often enough. And so when we started doing that, it steadily increased to 21%. But that's if we're being lumpers. And we're lumping our people with SLPs and our people with sustained alcohol use. But then if you become splitters and mark those out, the percentage of relapse right now in the program is about 15%, which is what we found similar to in the Accelerate AH cohort as well. Maybe a little lower than national numbers, I like to tell myself, so that I can keep doing this job, because it is kind of devastating when it happens. It requires a little bit of internal work to remind myself it's a relapsing remitting illness. It's okay. It doesn't mean you failed. It's all right. 5 out of 19 of these patients were women. And I am starting to get this niggling sense that our women have certain risk factors that are different than our men. They do tend to show up later with higher MELs. They have genetic predispositions to get alcohol liver disease at lower levels of alcohol use. There tends to be trauma histories involved and a lot of stigma, right? So getting the help, they're caregivers, and now all of a sudden they need all this help, and that can be a sticking point. Anecdotally, I have lost more female patients in this realm, and so I really do think that we need to pay more attention. It's great that MELD 3.0 is now a thing, because it does resolve some of the inequities that women face in this patient population, but we need to do more. It's not surprising to me that there is histories of other substance use disorders in these patients. What is a little embarrassing is that very few of them were engaged in active relapse prevention, despite the scaffolding that I'm going to talk about next. And only 7 of them were on medication-assisted treatment. So in 2021, we added an additional role to our post-transplant model. So they would see me, they would see social work, and now they would also see a substance use navigator. These are credentialed substance use counselors, and their job is to not only assess and kind of help these patients and do motivational interviewing, but also help them navigate the labyrinth of resources that is mental health care and addiction treatment care. This has been quite helpful, because now there's more check-in points with the patients. We're now running groups with these patients. We're encouraging them to get in aftercare. We're reminding them, we're using MI to see why they're not doing the things that they're supposed to be doing. And I don't have data as to how this has impacted things, but it has certainly helped us identify the patients at risk. We tend to meet, in fact, the meeting's happening right now and I'm missing it, but we tend to meet once a month to talk about our patients and to talk about, who are the problem children who need more help. How do we identify them? What is it that they need? How do we individualize care to them? Because everyone's story is a little different. So what we're really trying to achieve is truly individualized treatment plans. We want to be flexible and creative and not just kind of think inside the box. Like I said, we are resource poor, even though it doesn't seem like it, but we are. Our patients are. So we're really thinking about what are some additional resources available to our patients free of cost that can help with their insight, that can help with their we have a mindset of harm reduction rather than complete abstinence, right? That is no longer an absolute thing. We need to meet them where the patients are at, and we need to make sure that they're utilizing the resources that are available to them. For example, my clinic should not go unscheduled, even though it still does sometimes. So collaboration is key. We need to be in touch with our hepatologists and our surgeons, and our social workers and substance use navigators. My day starts with a phone call to the social workers every day to find out if there's anybody on their horizon that's having a hard time, if there's any new evals coming in, what is our game plan going to be? And I'm charming and they tolerate it. So basically my take-home points are, this is a relapsing remitting neurobehavioral illness. Early liver transplant is here to stay. And if I were to have my way, there wouldn't be multiple protocols, right? An early protocol and a 6-month and later protocol. There would be one way of evaluating these patients. But we need to recognize that it's not just good enough to give them a liver. We need to give them support, and we need to think about what is the resource landscape where we are and how do we build the support into a program. I was very shocked to find out at the transplant social work meeting that a lot of programs are doing this. 70% of transplant centers are offering early liver transplant. Not everyone's doing aftercare. So you get a liver and then into the ether you go, and you better figure it out. Otherwise, you're going to be in the hospital and no one's going to retransplant you. I think having an integrated behavioral health model is going to improve access issues. I think our hepatologists, who, to quote Dr. Winder, are now stewards of neurobehavioral illnesses, not just alcohol use disorder, but also obesity. They need to get a little bit more comfortable with that fact. We need to start educating them sooner. So really thinking about med students and, not having this dichotomy of psychiatric illnesses and medical illnesses. It's a whole person. That's the whole point of this meeting. I think I'm preaching to the choir here, but they need to get comfortable with medication-assisted treatment as well. They are the first line of defense. So patients may no-show me, but they will always come and see their hepatologist, right? They consider them to be so important in the fact that they're alive. And so that's our captive audience, and that's where we need to act. For our program, adding the substance use navigator role has been super helpful because we are navigating a resource poor region. And so the more we can do to provide scaffolding to these patients, the better. Thank you very much for your attention.
I didn't get well either, so you're good.
All right, well, today, last is the worst of the game. That was really good. Really enjoy being a part of these things. I hope you can sense how great it is to be a part of the Transplant SIG. We have a really great bunch of people who I'm grateful for. Full disclosure, I just got a cancer diagnosis and went through surgery. And I will say that some of the warmest support that I got of any of my colleagues are not at my institution, or people in this room. So when I'm standing here and I'm let me just say, I'm so grateful to be in the room with all of you. I was on some virtual calls a few months ago, and I didn't know where this was going. So to be all with you in person really means a lot to me. So the tumor's out, and knock on wood, things look good. But just really appreciate how kind everybody has been in here. It's just been wonderful. And since we're loving on Dr. Hafliger, I called her in 2017 or 2016, Sylvia, I can't remember, just absolutely hamstrung, but was still one of the worst cases I've ever encountered. So challenging. She took my call. I think it was like 30 minutes. She barely knew me. I knew her peripherally from her work in New York and some of the docs, and she was just wonderful. So spreading all the love around, everybody. So I was at the University of Michigan, and now with the wonderful Dr. Patel Shivali, wave to everybody. Got to get you plugged in here. We're at Henry Ford together and Michigan State University, and we're have some good things on the horizon.
I have taken money from industry, so if there's an aura of evil about me, that's what it is. I do some consulting for GSK around ALD. Doesn't have anything to do with the stuff I'm talking about. So I'm talking about VCA today, and I want to be kind of humble that I have a lot of experience because I sit on the VCA committee for the United Network of Organ Sharing, but my clinical experience is very low with this. I've not worked at a program where they do these types of transplants. The speakers and scholars that I respect when I'm in the audience are people who are open about what they do and don't know, and they don't try and talk bigger than what they are. So I want to be humble that I'm a student with you all when it comes to VCA. So it's literature based and cited. It's not like I'm out saying things I shouldn't be saying, but I want to be humble that I also have a lot to learn. And there may be people in this room that have more experience, and I want to be respectful of my limits. You see from the kind words that Dr. Hussein say where I spend most of my time. It's not in VCA clinically. So I just want to be honest about that. So Tom Starzl, is anybody from Pitt here? All right, so the Transplant Institute named for this amazing surgeon, and this is a wonderful book. It's his autobiography that he wrote before he passed away called Puzzle People. And there's something about VCA that just seems vascularized composite allograft transplantation. It just seems even a little bit more like these puzzles as we put people back together in some really interesting psychological ways in addition to the physical elements of their body. So VCA is non-life-saving, and it's the transplantation of skin or subcutaneous tissue, nerves, tendons, muscles, bones and cartilage, veins, arteries. And each of these has an intricate immunogenic profile that exceeds my expertise, but it is different one category from another and different from solid organ transplantation. And this does operate under the OPTN and under UNOS. So here's just I won't read this to you, but I put this together as just kind of a timeline as how this kind of unfolded in terms of chronology, and then giving credit, of course, to the researchers and clinicians who are responsible for the work that kind of led us to where we are. And then I went onto the UNOS website and just grabbed some of the data just to show you where this is happening and to show you how little of this to date is actually being done, and to indicate where more work is being done. And that the uterus transplant is a prominent element of VCA, and arguably just numerically the most prominent to date. To show this to you, ACLP flagged this, that's unreadable. I still kept it in here, sorry. But I just wanted to, you don't have to worry about the numbers, but just down at the bottom is the VCA, and the quote unquote traditional solid organ is at the top. So I just want to give you a sense of, we're talking about almost like a different planet from where solid organ transplantation is. So they do overlap though, let's not get ahead of ourselves. So where are they kind of the same? Well, consent and readiness and adherence, of course, you know, my colleagues have said beautifully today about looking at social support and psychiatric disorders and substance use. I mean, that stuff all holds regardless. But when we turn to solid organ transplantation, some of where it diverges from VCA is that obviously solid organ transplantation tends to be life-saving, life-prolonging. And so Dr. Hussein talked about some of that intricate evaluation and the high stakes when it's urgent, how compressed those timetables can be. And we're kind of calculating quality of life, and Dr. Matalik talked about how we're plugging in these ethical frameworks into these decisions. And most of the literature, of course, describes solid organ transplantation as opposed to VCA, which is life enhancing in ways we'll talk about. These grafts tend to be visible, which is really interesting. A whole dimension that solid organ transplantation tends not to encompass, apart from the person looks completely different once they've had the solid organ transplant. But the grafts themselves tend obviously not to be visible, but it can draw a lot of like media attention or ostracism or staring or body image issues, dysmorphia. And a lot of this work is linked to people's identity. So there's complex adjustments in terms of gaining or regaining certain functions and how that affects our partners. what type of rehabilitation regimen we have to take, part of that's very different from solid organ transplantation. The news wants to interview me and everybody knows who I am. And of course, the nature of some of these injuries include things like self-inflicted gunshot wounds or other horrible accidents, invoking all sorts of things with mood and suicide and trauma. So kind of barriers, obviously the immunological barriers are substantial. We'll look a little bit at some of the episodes of rejection that are pretty difficult to overcome. And we obviously have to balance quality of life with living on lifelong immunosuppression with the risk to kidneys and diabetes, pregnancy, all sorts of things that happen once we're immunosuppressed. Obviously, chronic rejection does happen to everybody who gets VCA, which threatens outcomes. And of course, there's not enough of this, not enough people are donors. So can we engineer tissues? And then xenotransplantation, can we grow these tissues in other animals that are immunologically compatible, which is an interesting element in solid organ transplantation as well as VCA that's undergoing research currently. So let's start with uterus. This began in dogs in the 1960s. And Starzl's book, Back to Puzzle People, he talks all about, I have 2 dogs and it's horrible to read this stuff, but it is really inspiring how long he spent in these like garages, these labs doing this stuff and just experimenting over and over and over again. And a really remarkable individual. It's understandable why he's so prominent. And the most common reason that we do uterus transplants is for congenital absence of the uterus or Mullerian agenesis, and it restores fertility. So for people who don't want to or cannot undergo surrogacy or adoption or foster care, this is another option. Significant psychological value derived from parturition. And part of this calculation is it involves multiple surgeries. This is the only VCA that where the organ is implanted and then explanted after the woman has her child or children, depending on how things go. They are delivered by C-section and obviously the hysterectomy. So this is all part of the calculation. Lots of ethical matters. What are the circumstances under which we are procuring a uterus, and what does that do in the case of a living donor to that individual, and all of these kind of careful calculations. You see chronologically the number of cases that have happened year to year in the last few years. The darker shaded bars are living donors and the lighter shaded bars are deceased donors. The impact of the pandemic is readily apparent there. These staying with uterine transplantation on the left there, you just see the viability of the organs post-transplantation up to a month. That's quite good. And then on the right-hand side, you see the viable graphs over time. Orange is deceased donor, blue is living donor, and how things are improving with time. This is showing just kind of a density graph of different events. Sorry, that's a little bit small. The onset of menses, the hysterectomy for graft failure, again, tends to be an early event if it occurs at all. The rejection episodes that can be inevitable. When the first delivery occurs, if the second delivery occurs, when a hysterectomy occurs after the live birth, and then any other transplant that occurred afterward. And then here's the gestational age of the fetus by year of delivery. Hard to make a lot out of this, but maybe a general trend of obviously the fetus being retained in utero longer during gestation. So these are called, is it Montreal? Yeah, the Montreal criteria. These have been revised a little bit, but just for a psychosocial audience, let's just look closely at recipients. So screening has not had her decision to undergo uterine transplantation deemed as irrational. Again, I want you to look at the flabby language here, very subject to interpretation. Does not exhibit frank unsuitability for motherhood. Again, yeah. That's the other thing. We've come up with a motherhood scale. the Michigan motherhood scale, no, we're not. Responsible enough to consent. Again, you can see why this has been revised since, but this was the original, the citations at the bottom. I also think I cite the updated version. For the donor, repeatedly attested to her conclusion of parity or has signed an advance directive for postmortem organ donation. Responsible enough to consent, informed enough to make a responsible decision and not under coercion. So not stuff that's really unique, but interesting to see it plugged into uterine transplantation. So I wanted to show that there. Again, not unique this either. The clash of patient autonomy and self-governance, the ability to make these decisions, to have some more control over my fertility and my family, but also non-maleficence, putting these organs in, lifelong immunosuppression, and as Dr. Matalik talked about, the calculation with regard to the donor. Obviously, biomedical risks, psychosocial benefits, I don't need to say much more. This has been treated very well thus far. But here's an interesting idea. Are we looking at an infertile mother seeking a uterine transplant the way we would look at an amputee seeking limb transplant, the way we would think about a burn victim seeking face transplant? It's nice to set those clinical vignettes next to each other and consider them for where they overlap in similarity. So let's move quickly to upper limb transplant. First transplant was in Ecuador in the 1960s, and then longer term survival of the graft achieved in Louisville, Kentucky in 1999. You can see the indications there, anything from medical conditions to trauma or infection. So obviously the question arises, what about a prosthesis? But of course these weigh a lot, they're uncomfortable, sometimes they don't have the usefulness, and then they don't give any feedback, biological feedback to the individual. So the benefits from transplant that we're aware of is obviously there's sensation and function, and they're cosmetically more ideal, and there's some data you see there about some superior performance in quality of life domains of their physical role, vitality, the emotional element of receiving the graft, and their mental health. So there's an added kind of psychological benefit. This allograft survival rate is quite good. You can see the cost of an upper limb transplant of $500,000 versus like a single prosthesis or bilateral prosthesis in the tens of thousands of dollars. Here's where they're being done on planet Earth, just so you can kind of see who's doing these: the United States, China, Europe. Here's how many we're doing, and you kind of see that over time. Here's kind of how they look. I love this stuff. I could have never been a surgeon, but I just, I wish there was ways we could show pictures of the phenomena that we encounter, because these journal articles have such rich imagery, and it's nice to show them to you. And just think about these people, what they got, how they changed psychologically and physically now looking like this versus the way they looked afterwards. It really is remarkable. Again, thinking about that puzzle people, it's wonderful to think that. And then in the bottom right there, you can see the age differential between when they were transplanted and their donors. So again, it can be decades apart. And then look at the amputation cause: explosion, crushing injury, electrocution, burn, explosion. Again, thinking about trauma. We don't have time to go into that, but very germane to our work as psychiatrists. So moving to head, neck, and larynx, similar theme, experimented in the animals, the wonderful illustrious Cleveland Clinic, first total laryngeal transplant in 1998. So just difficult to ever really rehabilitate all functions of the larynx to the point where you can speak, swallow, and breathe. Usually these transplants happen in people who have cancer. So you can think about, I think a lot about cancer now. You immunosuppress somebody who has cancer, and then you risk a whole host of things like cancer recurrence. So obviously no prostheses, but in a study of 11 patients cited there at the bottom, followed for 73 months at median across 3 continents, frequent death, unfortunately, frequent explant due to chronic rejection. However, in the people who did retain the grafts, functional voice, decannulation, and near normal swallowing by post-op year 2. So a substantial improvement. Again, this is face. So this is the kind of the most prominent one for obvious reasons, as we've evolved in humans and where we carry our identity in our facial expression. So this is a remarkable pocket of this that we're only going to peripherally touch during this brief presentation. About 40 of these have been done since 2005, traumatic injuries, burns, tumors. It's a remarkable improvement cosmetically, feeding, speech, social interaction, restorative function of our identity, lots of adverse events, unfortunately, including death. The right-hand panel here is just to show you the blue is the transplant, the red is rejection. I just want you to see the amount of surgeries and procedures. This is not like liver transplant. Just to kind of give a flavor that this is not the same population in yet another way. But again, this was also flagged by the ACLP that it's unreadable, but I just wanted you to see that the density of procedures, which is really remarkable, and why we would need an open-ended clinical relationship with people like this for multiple reasons, including the surgical burden here. So how do they do? Well, this is 23 patients, mean follow-up of 5.3 years. The green bars shows you that things got improved in these particular domains. Gray is not reported, red is impaired. So this is good stuff to do if you can do it. I put these bars here just out of respect for these people. Obviously, eyes are a big part of this. I just kind of felt funny that showing them and looking at them like this. So that was me that put those bars there. If you want to see their eyes, the citation's at the bottom, but this is really something if you just pause and look. And I think a lot about people who look like this. I don't know. I mean, it's because I'm a psychiatrist and I'm a voyeur, but when you see somebody who's impaired in this way, I'm always very moved by it. The opportunity for them to kind of move to something that would make them feel a bit better about themselves and save them from the scorn and the staring of insensitive people. I find that very inspiring. I think this is the case that Dr. Kaufman has reported on. This is quite a well-known case from Cleveland Clinic. We won't dwell on this, but again, just seeing this remarkable transformation. I love looking at these pictures and thinking about what this meant for her. Not a surgeon, so I'm not here to dissect this in any anatomical way, but I just like you to see the reparation that happens after something like this, which was a gunshot wound, and how it gets restored. This was a horrible injury from motor vehicle collision. Again, not the whole face. And then the donor actually was somebody who, a near fatal gunshot wound. And then this individual was able to restore his scalp. Again, I obscured his eyes. And here's how that looked kind of on the inside. So this is my last slide. So I think we're okay, Lisa. But I just want to give you kind of a rich distillation. That's a pun after Phil's alcohol presentation. But just kind of these are real cases. I didn't make these up, but they're not composite. So these are actual cases. The citations are at the bottom of just some of the psychosocial richness in VCA that we wouldn't necessarily see in the same way in solid organ transplantation. So this is a 44-year-old male who had his penis transplanted to restore, obviously, sexual function and the ability to stand and urinate. So remarkable opportunity for him. But the graft was removed after 15 days. No infection, no rejection. And it was the wife's psychological reaction to his new anatomy and the appearance of his anatomy, particularly that it looked swollen. And the verbiage from the paper was the patient was prepared to cut off the transplanted penis if he could not accept it. So gives you a sense, this isn't a psychosocial write-up, so wasn't a lot of data there, but what that must have looked like psychologically to the evaluators, how that must have been interpreted by a surgical team. So important to kind of pause and consider that, how different that is in a lot of ways from heart, liver, lung, kidney, pancreas, intestine transplant. 22-year-old male lost dominant upper limb, mid-forearm in a meat grinder. History of cyclothymia, suicide attempt at age 18, unrelated. Could not return to work as a butcher due to physical limitations. Disability and dependence led to a suicide attempt in post-op year 2, adequately treated to remission. So again, speaking to this long, open-ended relationship, I mean, I take Phil's point, you know, on paper, you're only going to see him for a year, Dr. Hussein, but she knows she's going to be open-ended. And I think this is another example of why we keep these relationships intact. 45-year-old female suffered gunshot wound in the face in a domestic violence incident. Functional complaints were many, including anosmia, eating through a straw, pain, public embarrassment. MDD PTSD treated preoperatively, but post-op significant psychological distress, activation of PTSD, anxiety related to others, seeing her new face, steroid-induced weight gain, all improved with time. It's kind of a nice, lovely, hopeful case. Finally, 48-year-old male with alcohol use disorder survived a self-inflicted gunshot wound and underwent 28 reconstructive procedures with suboptimal outcomes in each instance. Was euthymic at face transplant 6 years later. Imagine the suffering accumulated through that. Complicated 200-day hospitalization, persistent speech problems, and remained unemployed. Then a severe major depressive episode occurred 17 months post-op, which was adequately treated, but then had some financial difficulties and then hanged himself. Post-operatively, 3.5 years. So just really humbling stuff there. And it's important to kind of sit with it, I think. And then an ode to multidisciplinary practice. I mean, this is like, I feel like I march under this banner. I don't need to tell this audience that, but this is not something that is done by a single discipline. Lots of people involved, whether we're talking about uterus, upper limb. We need all our colleagues, and we need to be good liaisons, not just consultants. I'll leave it there.